Okay, I think I'm back. Our first technical difficulty of the morning. So we may have a few of these. We ask everyone to bear with us, be patient, and we have a really great team working behind the scenes that will get us back up and running if that is to happen again. So again, quickly, just the housekeeping items. One, you have a number for technical support. You can use the reset button if you've moved your screens around. Our presenters are wonderful. They've agreed to answer questions, and so you can use the Q&A function to ask a question of our presenters, and we'll get to as many as we can. Fourth, there's a chat box also below, and you're welcome to connect to others. So I've seen a couple people have already said good morning, and thank you for doing that. And I'd also like to thank Sharon Butterworth, the past chair of the Paso Norte Health Foundation and founder of the El Paso Behavioral Health Consortium, one of our founders. And of course, Enrique Mata, our senior program officer, and Juanita Galaviz, and all the people working behind the scenes to make this first virtual summit work for us today. All right, so let's get started. As you know, the consortium was founded in 2014 after we had done an original assessment of the mental health continuum of care. And it's really such a complex issue with so many moving parts and so many partners that assessment was so important, and also helping us build the relationships that we need for coordination, communication, and collaboration to really improve that continuum of care. So now, 6 years later, and 5 years after our 3 leadership councils were founded, we are back today to celebrate these successes of so many collaborations with multiple organizations and community leaders that are really making a lasting impact on the lives of families in our community. I just want to run through a few of these. It is very difficult to recognize all of them, but I'd like to highlight a few by each of our councils. First, our Family Leadership Council has seen increased collaborations for timely access of care for children, youth, and families. For example, the El Paso Child Guidance Center is working with a growing list of community organizations and agencies convening under the Trauma-Informed, Resilience-Oriented Learning Community. The El Paso Center for Children is leading the Strong Families Collaborative Work Group funded by the U.S. Department of Health and Human Services Administration for Children, Youth, and Families, Children's Bureau. The Paso del Norte Children's Development Center is leading a Help Me Grow collaborative effort focusing on children 0 to 3. Texas Tech Health Sciences Center El Paso is implementing 2 programs, CPAN, the Child Psychiatry Access Network, and TCHAT, the Texas Child Health Access Through Telemedicine Program, to provide timely access to child psychology consults in primary care and school settings. Project Vita and Socorro ISD are collaborating to help children connect with mental health services through the school system. These are just a few of the examples of the collaborations that the Family Leadership Council has worked on. There are so many more, and we're so proud of the work that's happening here. Equally, the Justice Leadership Council has seen multiple successes in the improved coordination of care. The County of El Paso, the Sheriff's Office, Emergence Health Network, and the University Medical Center of El Paso have coordinated and really transformed that coordination of care with jail, entry into the jail or exit from the jail, and or diversion from the jail. The County of El Paso, Judge Francisco Dominguez, Adult Probation and Emergence are also working to develop a mental health court for the county. And we know that one of the greatest successes has been the CIT program, which is a collaboration of the City of El Paso Police Department and Emergence Health Network. And so many more. Let's move to the Integration Leadership Council. They've been working to increase the availability of education and training of providers. Again, so many great examples of success. NAMI of El Paso has now trained more than 100 volunteer instructors for 14 different programs that are available for those interested in learning more. Emergence Health Network provides mental health first aid. The Texas A&M Colonias program, through the De Mujer a Mujer program, helps empower women at risk for isolation, anxiety, and depression. And we've seen a growth in the available services with organizations like Endeavors and the Cohen Military Family Clinic, the Rio Vista Behavioral Inpatient Treatment Center, and the VA Wellness Clinic on the MCA campus in partnership with Texas Tech. And of course, UTEP continues to advance training of providers across the continuum and really help make sure that we have a qualified workforce to work in all of our centers. This hasn't been without its challenges. And I think that the system in this short time has been tested. On August 3rd last year, we had a horrible tragedy, and we saw that the relationships established over the last 6 years were so important to help provide the families the care that they needed in a seamless way. All of our providers came together and coordinated and worked together. And I think that these relationships and the trials of August 3rd have helped us prepare in some ways and learn how to be resilient ourselves so that we could, and you all have, responded so well to the needs of our community through the COVID-19 pandemic. The challenges that the nonprofits and mental health providers are facing are well documented, and there are organizations now that are studying resilience and all of the challenges related to job loss and school closures and the lack of community connection during a pandemic, increases in substance abuse, domestic violence, child abuse, and neglect. So at these times of trauma and crisis, this is when our system is tested even more, and I'm so proud of how our organizations have been able to respond to the needs of our community during these traumatic times. We know that this is really the result of the time that we've spent together and the relationships that we've built over the last 6 years, and our future is really filled with optimism, kindness, and caring. Our present is filled with optimism, kindness, and caring. And from me to you, thank you so much for that. We have a great program today. We will hear from Linda Rosenberg on what we're seeing at a national level as it relates to mental health and addiction needs. Melissa Rowan and John Petrila on how all of our consortium partners are engaged in a comprehensive behavioral health system assessment to acknowledge where we've been, measure improvements, and help us set goals for the next 5 years. And then Dr. Andrew Keller on how this upcoming session is likely to be, the issues that will be on the table, and how we are preparing to ensure that we don't lose ground on the great advances in mental health and behavioral health services for the state of Texas and in our community. All right, so it is now my great pleasure to introduce our first keynote speaker. Linda Rosenberg was appointed to the faculty of Columbia University's Department of Psychiatry in 2019, where she serves as Executive Director for External Relations, focusing on public and private sector partnerships that expand effective mental health and addiction services. Prior to joining Columbia, Linda was President and CEO of the National Council for Behavioral Health from 2004 to 2019. Under her leadership, the National Council became the nation's largest mental health and addiction education and advocacy association with 33 plus member organizations serving over 10 million Americans. Linda was New York State's Senior Deputy Commissioner for Mental Health until 2004, during which she opened New York's first mental health court, designed services and housing for the homeless, and led the growth of community treatment and supports for adult and children, including the expansion of child-based services. In addition to serving on Columbia's faculty, Linda consults with nonprofits, foundations, and private sector companies on the design and delivery of mental health and addiction services and serves on numerous national boards, including the Executive Committee of the National Action Alliance for Suicide Prevention, the Cohen Veterans Network, the Meadows Mental Health Policy Institute, NetSmart Technologies, Triad Behavioral Health, and Effective School Solutions. We are so honored and pleased to welcome Linda back to El Paso, virtually this time. And it is so fitting that she joins us today from New York, because she was with us here with this group in 2015 as we launched the 3 leadership councils that have led this work over the last 6 years. So Linda, welcome to El Paso.
I am delighted to be with you. I have become a promoter of El Paso since my visit. It's a very special place.
Well, we so wish that we could be doing this in person, of course, but are so grateful to you for taking the time to be with us in this virtual environment and kind of give us a glimpse. Certainly when we were thinking about the summit last year, we wouldn't have predicted the circumstances that we're in. And so it creates additional context for the work in mental health and addiction.
It does. It does. And, I'm delighted to be able to share what I'm seeing across the country as I talk to groups like yours, as well as our experience here in New York.
Yeah, terrific. All right, with that, I will turn over the agenda to Linda Rosenberg.
Thank you so much, Tracy. First of all, not only thank you, Tracy, but I want to thank Enrique. He always reminds me of a quote that goes, "People may not remember what you say, but they'll remember how you made them feel." And he's someone who not only does good, he makes you feel good. So thank you so, so much for having me and for being such a wonderful colleague. I also have to give a shout out to Sharon, who I saw in many of the pictures that were up on the screen. One of my co-board members of the Meadows Policy Institute, and of course to Andy and John and Melissa. I'm very proud to be associated with Meadows and the fine work they do, not only in Texas, but nationally, and allows me to maintain a connection to Texas. My very, very first visit to Texas was in 2004, before I actually started my job at the National Council, when Danette Castle invited me to her conference and somehow convinced me that Texas is the best shaped state. I still don't totally understand that, but she was very convincing. So I'm always glad when I have a chance to be with people from Texas. One of the things during this past year, 2020, has been a very difficult year. One of my best friends is a travel writer. And what she's been writing about is really her experiences over the years visiting different places. And because I am a lover of travel, both for business and for pleasure, I've started to do the same thing. Not writing about it, but certainly thinking about it. And El Paso is one of those places. And I think when I think about El Paso, now I am not able to move my slides. Is that something I'm doing? Yes, good. Let's go to the next one. Okay. And when certainly I think about El Paso, I was seeing the letter that Enrique wrote. I think it's the El Paso Times that was publishing it. And what really struck me was what Tracy was talking about. And she has that same, what were the words she used? Optimism, kindness, and caring that really is embodied in El Paso. And the progress you've made is very impressive, but probably most impressive and most important into the future is really the trust you have in each other. That comes through, and it's enabled the progress that you've made. I'd like to move the slide on. And I hope I'm the one who's being able to do this. So there's another quote, and this is from former President Obama. If you had to choose one moment in history in which you would be born, you choose right now. And I know we don't feel that way this year, perhaps. In the short term, this is a very difficult time, and I'll talk a little bit more about that. But I think when you look at this slide and you look at the progress we've made over decades and decades, it gives you hope and it makes you believe what Martin Luther King taught us, which is that the arc of the moral universe is long, but it bends towards justice. And I think that is something we all have to remember during these very difficult times. Next slide. I don't know why I'm having some trouble with this. Tracy mentioned Cone's Veterans Network, and one of the last things I did before I stepped down from the National Council was with Cone Veterans Network. I serve on their board, and it was really a survey of 5,000 Americans about how they view the importance of mental health and addiction services compared to physical health. And I think it really underscored what I had been sensing, and many of us had, which is Americans were understanding the importance, cared about it. And if you look at some of these numbers, 6 in 10 Americans, thought mental health and addiction was just as important as and as essential, said 76%. And I think, you in your foundation and in groups like yours across the country have put tremendous effort into anti-stigma campaigns, into talking openly about your own personal experiences. And I think that really has made a difference. One of the findings from this survey that I think is also important is how much younger Americans are comfortable with the notion of talking about emotional distress. One of my proudest souvenirs or memories from the National Council is my Bipolar Babe t-shirt that a group of teens gave me. Who were talking very openly. I was at the hairdressers, and the assistants who wash your hair were comparing notes about their treatment for anxiety. The sad part of it is, of course, that people are struggling with things like anxiety. The good news is they're talking about it and getting help. So we have, come a long way. And certainly we have, those of you who read People magazines, it's one of my guilty pleasures. And if you look, almost every week, there's a celebrity talking about their struggle and their recovery from addiction or from bipolar disorder, depression, anxiety. And certainly, you've, again, been in the forefront. I think you've trained over 7,000 people in mental health first aid. 2.5 million Americans have taken a mental health first aid course. And since we introduced it in 2007, there are many campaigns like that. Meadows has a campaign, Okay to Say, and they're all good and all important. But of course, I'm very pleased, to have been someone who brought mental health first aid to the U.S. and participated in really changing that conversation. But we have lots of work to do. And I think this slide really demonstrates that. Let's move on to the next slide. One of the every year there's, a new kind of catchphrase, and I'm going to cover a number of them in my talk this morning. One of the most tragic has been this notion of deaths of despair. And I think it was actually in 2015 that the two economists coined the term, got the Nobel Prize for looking at why the mortality was going up and the length of our lives crimes in the US for the first time was going down. We weren't gaining more years. And when they looked at it, they expected to see diabetes, obesity, heart disease, but what they saw instead was an epidemic of addiction, of suicide, and of diseases related to alcohol use. And so those were really startling to all of us. But when you look at the statistics, and I think this is very important because, Tracy mentioned that I serve on the National Action Alliance, and we spend a lot of time looking at young people because they're our future, and their suicide rate has gone up, as have all the rates. But when you look at the real driver, what you're really looking is at white males accounting for the majority of suicides, and it's firearms that are, is the vehicle that is killing people. I think when you also look at this, another group where we're seeing increased rates is in young Black men, young Black boys. And we'll talk a little bit more about structural racism in our country, and it may be that we're seeing some of that. Clearly, suicide has an impulsive piece to it. It's multi-dimensional, multi-causal, but there is an impulsivity, and that's particularly true of young people, and it's particularly true of people who have access to firearms. So I know we're a country that believes strongly in people's right to have firearms, but we have to do a far better job at keeping it difficult to access your firearms when they're at home or in a nearby location. So next slide, please. Another, buzzword, and I love, kind of puncturing the balloon of buzzwords. It's a personal kind of joy that I get, I think. If I hear social determinants one more time, it's such a euphemism for really being poor is bad for your health. The poorest amongst us die 13 years younger than the richest among us. That's most telling. And when you look at the social and economic environment, it accounts for 40% of the deaths. And that disparity is not going away. And really, as much as mental health agencies and substance use agencies and even insurance companies talk about social determinants, we're really talking about social policies. And we'll get to a little more about that. Next slide, please. So if being poor is bad for your health, being a person of color, regardless of your income status, makes you more vulnerable and makes you more susceptible to illnesses. We have seen it in COVID. You are 3 times more likely to contract the virus and twice as likely to die right here in New York if you are a person of color. And that's regardless of your insurance status and, as I said before, your income status. And we see it also in mental health. I'm very conscious of it's very easy to say, well, it's not me, it's other people, structural racism is all around us, but we have it right in our own services. And certainly in New York, we're starting to struggle with that. When we look at our secure units in state hospitals, they're full of young Black men. When you look at expulsions in school, even though we have school-based mental health services in almost every school, you're more likely to be expelled and suspended than you are to get treatment if you're a child of color. And it's the same with substance use services. So I think we need to look at ourselves. I don't think taking a course about implicit bias is going to make this go away. I think we need to measure these numbers and we need to keep ourselves accountable to them. Next slide. So I think, we've coined the term at Columbia, a country on fire, and we've been doing a series of panels because, COVID exposed, these tremendous disparities between whites and blacks. And then we had these horrific murders, which have been going on. And certainly, George Floyd captured everyone's attention. But long before that, we had, a solution to the crack cocaine epidemic was mass incarceration. And we continue to have a growing gap between, the poorest and the richest among us. One of the things you see in New York is really the middle class who can fleeing the city because of the virus. What the richest are doing is they're keeping their apartments, their condos and co-ops, and just buying homes, out in Long Island, in Connecticut, and in upstate New York. And so they get the best of both worlds. And we have to make a decision as a society about whether that's tolerable. And if it's not, what we choose or choose not to do about it. Next slide. So I think that the true north for all of us is that we have available, effective services, and we don't. I think what that survey with CVN that we did showed is that what people are grappling with is not about saying they need help. And actually, veterans scored the highest in that survey around willingness to ask for help, but they don't know where to go. And they don't know how to pay for it, which was the reason Steve Cohn established the Cohn Veterans Clinics. But not everybody is a veteran. And so what do we do about everyone else? Every week I get phone calls from family and friends who have a problem, don't know where to go. And when they do and they call, they're not taking new patients. There is a tremendous, entry process that they have to go through. And so, this available, effective services continues to be a struggle for us. Next slide. So I'm going to quickly go through really the 4 questions that you'll see on the next slide. Which is where will we get our care as we look over the next, 24, 36 months, maybe 5 years. And I love that you're circling back after having decided on a path, you're actually closing the loop. That rarely happens. And it's one of the reasons we don't make as much progress, I think, is that there often is so much turnover that people start again. And they don't go back and measure how they've done and look at the same issues over again. We're going to look at how will we pay for care, who are the people that will care for us, and what kind of care should we want. So next slide. And then let's go to the one after that. One more. This is it. So let's talk about the struggle to get care. I think most people are not, receiving Medicaid services for serious mental illness. Most people have commercial insurance or commercial Medicaid insurance, and they have illnesses that respond to treatment. We have effective treatments, but it's almost impossible to get it. Joe Parks, who's the medical director at the National Council, when he was the Medicaid director in Missouri, called all the people that were listed on the insurance company's network. And some of them, in one case, he got a blimpies, and in many cases, the numbers no longer worked. So getting care is not easy, even if you have insurance. And of course, you have rates that are paid to practitioners that once they are established, no longer will accept. And so we, next to cosmetic surgery and dermatology, are the industry that is a cash-only business. And so again, you have this very much a two-tiered system of services. And then I think on the public side, we have created a myriad of services for people with serious mental illness. Every funder wants something new. Every new state government wants something new. And the result of that is they're all under separate auspice. And so they all have their own set of rules to enter and to leave. And it really is a maze. And so the calls I get are not just for commercial insurance. They're also for people who have relatives with serious mental illness and they just can't make head or tails out of the array of services. So really it's that navigation that has proven very difficult. Next slide. Tracy talked a little bit about your efforts around integration, and certainly it's something that everybody wants. I love one-stop shopping, and more we're seeing that certainly here in the community I live. We have a big system called Crystal Run. I can go get my blood taken. I can see my cardiologist. I can see my dermatologist, and it's really quite terrific. And I can starting to be able to get some screening for mental illness and addictions, but it is very slow going. And I'm going to talk some more about that. So let's go to the next slide. One of the things when we talk about integration, we paid a lot of attention to and should is really those people who have comorbid mental illnesses, addictions, and serious physical disorders. The people who cost us the most, it's when we started looking, another kind of word, population health, very important concept. And we spent, a lot of time on it, something, many communities have invested in identifying those, what are sometimes called super utilizers. And one of the first places that began that work was in Camden, New Jersey. I just learned from Tracy, she actually comes from New Jersey. So let's go to the next slide because something interesting came out of it. They were very brave in Camden, where they took a community, a number of city blocks, took the people who were the sickest, wrapped services all around them, and then they called in MIT to do a random clinical trial to see what the outcomes were. People liked the services, they got better services, but compared to the control group, they cost just the same. It was not a saving. In fact, whoever is costing us a lot of money right now, in the future won't, and there'll be new people who cost us money. I think it's called regression to the mean, but you're going to need somebody who understands statistics better than I. So I think for me, this kind of helped look at this myth of mental health and addiction care saving money. I don't know anyone who needs treatment for cancer or diabetes who talks about if they get treatment for their illnesses, they're going to save money for other specialties. So I think that's something we need to keep in mind, that people need treatment because they're ill and they're suffering. And we wouldn't deny it on the basis of money, and we don't for things, like breast cancer or lung cancer, and we shouldn't be doing it for schizophrenia or bipolar disorder. So let's go to the next slide. The piece of integration that has the most evidence is something called collaborative care. Andy Keller, who's going to be speaking to you, is one of the leaders really of something called the Path Forward, where businesses are looking at their employees and trying to get them a state of the science services in mental health and addictions. And one of their points is around collaborative care, where you go to your primary care doc and where there is availability of a consulting psychiatrist, usually virtually, and there is also a care manager. So let's, we'll get back to that when we talk about paying for things. So let's move to the next slide. 16 years ago when I began talking with the National Council's members, and they have 3,300 member organizations, when I began to talk with some of those members, at that time there were about 700 organizations, they were not thrilled that what they saw as their association was talking about integration, was taking business and saying that some of it could be done in primary care and schools, and it was not popular. But but, we soldiered through. One of the things, I believe strongly in is an association must both serve but also lead. And so that was something that was good for the American people. And what happened is, of course, is we continued to grow services in other settings, and it just continued to grow the specialty sector. It really wasn't an either or. It was, we will always need a specialty sector, just as we have in cardiology and oncology. I get some things in primary care, and other times I need a specialist. So I think, that isn't going to go away. And as we look into the future, we will continue to have specialty care. I think we will have better specialty care because we're also attending to physical needs in behavioral health, at least screening, some minimal care, and triage to primary care as needed. And I think that's good on both sides. Next slide. Indeed, how will we pay for care? And let's go on to the slide right after this. This is one of my favorites because, again, going back to this notion that if we do good work in behavioral health, we're going to save money in other parts of healthcare. And I know other speakers may be coming on who disagree with me and say, indeed, that is true. I think it's true when you look at a current cohort of patients. I don't think in the long run it's true. And there's something called the iron triangle of healthcare, because all politicians promise three things when they talk about healthcare generally. They promise to increase access. More people are going to get care. They're going to get better care. They're going to improve quality, and they're going to control costs. And this JAMA article and what this health economist said and showed is you cannot do all three. You can maybe do two at a time, but if I improve quality and I treat more people, costs are going to go up. If I want to control costs, I'm going to have to control access, and I may even have to leave quality alone. So I think that's an important thing for us to understand as we make our pleas. And I myself have been on the Hill, in DC with groups that always promise to save money, but I'm not sure that that's an honest path or actually the way to go. There is, of course, misuse and overuse, and that is one way to save money, but not by giving better care to more people is that the pathway. Next slide. Something else we've been hearing about for the last 2 or 3 years up until the pandemic was value-based reimbursement, VBR. For a while, I used to show a unicorn when I talked about this because everybody was talking about it and I hadn't seen much of it. And if you look at who is doing value-based reimbursement, which means you get paid based upon your outcomes or at least reporting of outcomes, there is some movement in general hospitals because Medicare has focused in this area. When you look at freestanding psychiatric hospitals, residential treatment for addictions, glacial. Hardly any movement at all. And if you look at community behavioral health, what you hear is from the plans, the payers, that the community organizations aren't ready. And what you hear from the community organizations is the plans don't want to listen to them when they put a proposal forward. So movement, again, very slow. And the people who've done the best, as I can determine, in value-based reimbursement have been the consultants, because it's been confusing about what is it exactly. There's been so many different kinds of VBRs that consultants have really had lots of business trying to sort it out, both at the government level, at the insurance level, and certainly at the practitioner level. So next slide. This is a slide that shows the number of community organizations that are participating in VBR arrangements. And the numbers are misleading, the percentages, because this is the percentage that has some small pilot, and it's mostly small pilots. But I think there is a lesson to be learned. And as we look into the future, the one that we need to pay attention to, and again, the path forward has this as another important point in their agenda, is the shift to measurement-based care. When I was at the National Council, I used to say, measure something, measure anything. And you don't need very fancy measurement systems. You just have to pick something. And so next slide. Next slide, please. Oh my God. Okay, so let's look at the community safety net. Even though I'm at a large academic medical center, and oh, by the way, I just told the chair of the department yesterday that when I was responsible for operations in the New York State Office of Mental Health, it was easier than trying to move an agenda at a large medical center, academic medical center. So I'm learning quite some interesting lessons about the complexity of that setting. But one of the things is, my heart is in the community and is it giving people living in the community and their families the best possible care. But when we look at our, what we call our community behavioral health safety net, we certainly know that it is a struggle. And it's a struggle for some very basic reasons, right? Even when you talk about value-based reimbursement, as I said before, how many community organizations can enter into a contract and then lose money on it? They don't have those kind of reserves. And when you are entering into it and you have the chance of getting some upside, some gain sharing, you need a system to monitor all of that accounting. And they don't have the infrastructure for that. And now that I'm serving on some boards of companies in the behavioral health space, what I know is what they do is raise hundreds of thousands and millions of dollars. They actually call it rounds. There's rounds A, B, and C. There's probably D, E, F. I just haven't seen that yet, where they keep raising more capital even when they're not making money yet. And what do we expect in the nonprofit world? We expect them to be able to shift and to change and to adopt new things without any investment in capital. And so I think we have to be realistic about that. I think the other thing is when we talk about a safety net, FQHCs, federally qualified health centers, have cost-based reimbursement. Often behavioral health services and centers, they get the fees that are set with what the state has left over. And that is quite different than cost-based. And we're going to get to that when we talk about staff. Let's go to the next slide. So what we've seen is community-based organizations come together in places like Illinois and Missouri, in Maryland, in New York. They form these IPAs in order to think if they come together in a new entity that can negotiate with the payers, with insurance companies, they'll get better deals. It's another thing I've seen very little play out. Again, the consultants who've helped organize them, the attorneys that have been involved in setting up the legal structures have all done very well, but I haven't seen many contracts come through the IPAs. But I certainly understand the desire to try to organize to be more effective and more efficient. Mergers, again, on the for-profit side, I see mergers, acquisitions, ongoing. And by the way, everybody in charge makes money when that happens. In a not-for-profit merger, boards often lose their board seats. You can't have two CEOs, you can't have two cabinets, and nobody on a personal level benefits. And although they should be doing it for the greater good, they often also feel like their mission will disappear. So as many probably mergers as we should see, we see actually relatively few. I think the other thing is we see tremendous amounts of private equity and venture capital in behavioral health. The numbers are over $4 billion, but it is not in the not-for-profit world because, again, they are in it to be able to turn it over in 4 to 5 years and sell it for more than they originally invested. And they always do, again, even if they're not making a profit. But that's a whole other talk, and we'll get to that. And they are also committed to doing better for patients, but they need to make money while they're doing it. And I'm going to talk a little bit about how they think they can do that and why they're not interested in the not-for-profit face-to-face world. So at the National Council, what was the answer? We thought FQHCs were the answer. We encouraged members to become FQHCs, great way to integrate care and a great way to get cost-based reimbursement. But not everybody could become an FQHC. So we went and took what was our notion of centers of excellence, and Debbie Stabenow, the senator from Michigan, when we went to her around some legislation that would create this parity with FQHCs, the name somehow became CCBHCs, Certified Community Behavioral Health Clinics. Don't blame us. But most importantly was we were able to get a piece of legislation through for a demonstration project. And now we have 33 states that have CCBHCs. Only 10 have Medicaid CCBHCs. And that's because Congress and the administration have been heavily Republican. And when that happens, Republicans don't want to expand Medicaid. It's a basic belief. They'd like to actually block grant it. And some of you may remember all those attempts in the Bush administration and early in the Trump administration. And so what we've been able to do is really move grants in preparation for perhaps a change of administration and a change of thinking. But even in the first 6 months, in those original 8 states, they were able to increase the number of people they treated by 25%. They hired doctors, they hired peers, they hired nurses. And have made a big difference. They added service lines like medication-assisted treatment to their portfolio. So I think they still need to be refined, and we always knew that. We're dealing with SAMHSA and CMS and, this kind of negotiation. But no one has been able to go back in and do refinements because they're still in such infancy and there hasn't been that Medicaid commitment. But I think it gives really behavioral health organizations a platform from which to grow and improve the way FQHCs did over the years. So next slide, please. I'm watching the time carefully. So let's look at healthcare into the future. We spend a lot of time talking about healthcare will be 20% of our GDP by 2026, that it takes money away from education, that it's outpacing everything else in our economy, and we wring our hands and we keep talking about getting all that under control. But if you look at the other side of this slide, what you see is in practice, healthcare is a business and everybody's making money. In fact, insurance companies, pharmaceutical companies, consulting, technology startups, and investors are all making money based on healthcare. And so I love this again. I mentioned Joe Parks before. This is his quote. We have the healthcare system we built. Every time we have to make a decision, we make a decision good for business. And I think that's true. So what will we see generally as we look towards perhaps a change in administration? And if that should happen, I think we will see all states expand Medicaid, even Texas. I think we will see Medicaid cover more and more people. We may see a public option in the Affordable Care Act if it survives the Supreme Court. But we will not see a throwing out of what we have now. We won't see Bernie Sanders' vision of healthcare, I don't think, anytime soon. I think we have a big vision and then we make incremental progress. And I think that's what we'll continue to see. Next slide. Let's go to the one after this. When we talk about who will care for us, up until the pandemic, what we really saw was, this really full employment. And the crisis that behavioral health was experiencing in recruitment and retention, so is every other industry. The difference is that we were not able, the way private companies were doing, to promise people, if you stay with us for 2 years or 4 years, you get a sabbatical. We feed you all day. We allow you to bring your pets to work or pay for their daycare. We just couldn't compete. And so the best and the brightest were following the money. And even within healthcare, behavioral health, again, which was often set on fees, were not able to compete with the VA, not able to compete with FQHCs. And it's been a problem even for the Cone Veterans Network that when they are in partnership, as they always are with a community agency, they have to be sensitive around salaries. So I think we were really struggling and are continuing to struggle even through the pandemic. But if we go to the next slide and we look at the whole notion of telehealth, I think for me, the most interesting thing was all the resistance against telehealth. And resistance usually comes from staff, by the way, not patients, who love convenience. We all love convenience, right? I have Amazon Prime at my doorstep, every day because I've ordered something the night before. But I think, we were very slow. Of course, regulations were very slow to change. And so we were using it, but using it very little. Well, practically overnight, every organization, including Columbia, in our faculty practice, in our programs for schools and elsewhere, converted immediately, as did all the National Council members. And one of the things was you now could get paid for it. The regulatory barriers were lifted, including giving, and introducing people to medication-assisted treatment, to being able to practice in other states without going through licensure in most places. There was a tremendous change. And I think what people are finding is, as I'm hearing and speaking to CEOs of organizations, no-show rates have gone way down. It's much easier. I have a therapist. I used to travel to her office in New Jersey. Now I see her over Zoom. I love it. I think we're doing just as well. I may want to see her again in person from time to time, but primarily I think we will continue this relationship even, God willing, after this pandemic is over. So let's go to the next slide. I think the other thing that startups that are funded with private investments, they know is the way they're going to make money is by doing things remotely. That face-to-face costs too much. They can't, very few of them want to buy private practices and keep them face-to-face. There just aren't enough hours in the day. And the other thing that they can do, in addition to offering this immediate access, is millennials want to work from home. And even I want to work from home now. I miss going into the office, but I don't think I want to go back full time, even though I have a great office overlooking the river at Columbia and I get to see and brainstorm with colleagues. There is something very comforting and familiar with working from home. And millennials knew that long before a boomer like I appreciated it. I think the other thing is when you're doing things over Zoom and video is you have a transparency, because in these startups, the interactions are monitored and supervision is based upon what actually is going on between the practitioner and the patient. And that is a big step for us. We've always been behind closed doors. We didn't even, the way your medical doctor does, is have a nurse in the room with us. And so I think this level of transparency can also lead to improved quality. Next slide. I think the other thing technology does, in addition to improving the potential to improve technology, to make consumers happy and engage them, I think the other thing it does is really helps us analyze in bigger numbers what people do well with. Sloan Kettering was one of the first hospitals that when you went in to be admitted in a very difficult time, it's a cancer center, they were able to, by using all the data and the medical records they had accumulated, was see who was likely to be susceptible to infection. We're going to be able to do that on the mental health and addiction side. And we're going to be able to do it because of using technology. So I think technology is something that's here to stay. We're, going to be using, and there are companies that are investing in cell phones. They can tell by the GPS in my cell phone whether I'm depressed again, because am I going, to call, and am I going to visit my friends, which is all tracked? Or am I just staying in one place and not even using my phone very much? So I think we're going to see more and more of that. I think the other things that CCBHCs give us is the ability to pay for some of this technology in our cost-based reimbursement model. Next slide. So what kind of care should we have? And let me say, there are pockets of excellence everywhere, in every community and in every state. What is hard is spreading those pockets of excellence. And one of the reasons is practice has to be aligned with policy. One of the things at the National Council that we did from the very beginning, when we believed in integration, we went to the Hill with our initial data, and we showed them, and we got what is still continuing to be the SAMHSA integration grants, which really number in multiple of hundreds now all over the country that have moved that agenda. When we were interested in mental health first aid and we believed the public craved information about how do I know something's wrong and what do I do about it, we went to Congress and we helped get the Project Aware, which put mental health first aid in schools. When we wanted centers of excellence, which combined initial primary care with substance use and mental health and looked at measurement and outcomes, we went to the Hill and we got CCBHCs. I think you're doing that in Texas. It's one of the things I love about Meadows is when they talk about their moonshots, conquering depression, all of the things they're interested in, they have a policy play. I call it a play, but that is how you get something institutionalized. Next slide. So parity, we've had a law, I think it's 12 years now, or no, 10 years, or we celebrated the anniversary. It seems like not long ago. It is still a basic fight. And if you look at the details of this slide, and I don't want to go through them, we still see insurance companies doing whatever they can to get away with doing the least that they have to. And that's, that's their businesses. And sometimes because they have such charming, educated people involved in dealing with us, right? Their VPs for behavioral health, the head of Optum, their medical directors, all talk the right talk: recovery, choice, population health, every good buzzword, and they're good people who've done good things. What we forget is they have stockholders, and their businesses. And every quarter they have to report their profits. And so they are not going to do what they're not made to do. And one of the things at the National Council we talk to about our network of state associations is your moment in Medicaid managed care is when your state is going to put out an RFP. And you have to contribute to that RFP because companies will do what's in their contract. Next slide. Next slide. We skipped measurement-based care. I just want to go back to that for a second. Thank you. I think of all the things, this is the most important. In 1997, I became the Senior Deputy Commissioner at the New York State Office of Mental Health. And I was part and had an initiative called the Winds of Change, which, by the way, all the providers made fun of. I realized that in a short amount of time. But it was really to move evidence-based practices for people with serious mental illness based on the Port recommendations, which came out in 96. I actually carried the Port recommendations with me up to Albany, and I was going to really ensure that everyone we funded through Medicaid and state grants was going to practice according to the evidence. Well, I left in 2004, had almost no success. And one of the things I've realized over time as we've continued to talk about evidence-based practices is that people practice based on the evidence and change their practice when they're measuring how people are doing with standardized instruments. And that's why people do so well in studies. When you do research studies, you measure with a standardized instrument every time you see the patient. And we don't do that. So my message is, we're going to hear more and more about measurement-based care. I'm also part of a national response to COVID that the head of NIMH is chair of with Patrick Kennedy, and it's going to be one of our national recommendations. So I do think this is something worth noting. Let's go on to depression. One of the things Enrique talked to me about was new treatments for depression, and there are lots of them. And you know, one of the things that's come back from the 60s and 70s has really been the use of psychedelics. And, you know, it's everything from peyote to mushrooms that, again, are being researched. But the one that really has had a tremendous impact is ketamine or esketamine, which is for treatment-resistant depression. And I know you may hear more about depression as one of Meadows' moonshots. It is something that is very treatable, and that, of course, is the biggest burden of disease for our country. Next slide. Let me talk about suicide prevention just for a minute. And you can look at this slide. There are things we know that we must do that we are not doing. And if we are going to move an agenda, it is really around screening, both in specialty care and particularly in emergency rooms. It's about safety planning, and it's about follow-up telephone calls that are very important. And it's important about the kind of care we deliver. CBT, DBT, not just chatting, and the medications that work, clozapine for people with very serious mental illness and esketamine for people with treatment-resistant depression. Next slide. This is medication-assisted treatment. It is the treatment of choice. We have made it difficult because only if you go through significant training can you prescribe it. Even if you're able to prescribe it as a physician for pain, you can't prescribe it for addiction. And that is another policy that we need to move and change. But I think we also need to remember that for a while we thought if we reduce the number of prescription pills, we'd have overdoses and addictions go down. That has not happened. We may have the same with medication-assisted treatment. Again, we need to understand addictions better, and people need communities in which to recover. Next slide. These are just some of the social costs. As someone who's been involved with people with serious mental illness, we often focus and continue to on homeless and the seriously mentally ill. But if you look at these numbers, what you'll see is substance use drives homelessness, even exceeding mental illness. And that when we talk about mental illness and addictions, we're really usually talking about depression and anxiety. The other thing, of course, again, when we talk about criminal justice and people filling our jails, it's people with primary substance use disorders who also get diagnosed with the depression, anxiety, and even bipolar. Next slide. Coordinated specialty care, it is our state of the science in terms of people developing schizophrenia and serious mental illness. I know it's something that, Meadows, again, has been promoting, and I know all around the country, especially since part of the block grant can be used for these services. And I think what we need to do is make sure that parity, that commercial insurance pays for the cluster of services that make up coordinated specialty care, as they should be paying for case management and ACT. Next slide. Finally, and my final real slide is about 988. So the other shift that we're seeing, and I think you are talking about it and will continue to talk about it, is this notion of why do the police respond when someone has a mental illness, and when I have chest pains, EMS comes. And how do we make that shift? One of the ways is 988, which will become and will within 2 years be the number that people will be able to use. The issue is, of course, this could take years to put in place. And what has to go along with it are the kinds of services that you need to have trained responders and then places to take people in an emergency. And right now, as we speak, legislation is being worked on, certainly in the Hill, to both a senator and a congresswoman. Both women have developed the very sketchy outline. I talked with my former lobbyist when I was at the National Council. He still works with them, and got an update this past week. And so I think this is a fundamental shift in really an expansion of integration is the way to think about it. We've worked hard to say mental illness and addictions are part of health. There is no health without brain health. And what we're saying now is if it's an illness, then we should be responding like it's an illness. And I know that you've done some interesting things, I think, in Dallas, and I know Meadows has been involved in that as well. And you may hear about that from John, Melissa, or Andy. So let me end with another quote from the richest man in the world. If you look at the next slide, I think you'll see the final quote. And what I like about this quote is the end of it, which is complaining is not a strategy. And I think that's the most important things. We have lots of things to complain about and lots of work to do, but just complaining won't get us very far. And I'm very pleased to be with a group like yours today who does so much for so many. So thank you very much.
Thank you, Linda. Can you hear me okay?
Yes, I can.
All right. Well, I so appreciate the wonderful presentation, just so much information to think about. I think it's helping our participants understand the broad and far-reaching opportunities that we have to improve our mental health and emotional well-being. We have a little bit of time, and I had a few questions that came in. I'd like to see if you can maybe respond to one or maybe two here. Let's try one. Ms. Rosenberg, U.S. Supreme Court scheduled arguments for a Trump administration-backed lawsuit against the Affordable Care Act for November 2020. Thoughts?
Well, that's a tough one, right? Obviously, there are thoughts on both sides of the aisle. Yesterday, I had a little bit of time, and I was listening yesterday evening to some of the questioning of, the newest nominee for the Supreme Court. There is tremendous worry about losing the Affordable Care Act. This goes back to the fight we just can't seem to solve. Is healthcare a right or is healthcare a privilege? And as a country, we continue to be divided. So I don't know how they will rule. I'm hoping, we've had Roberts on our side. This time, though, it's a very different court with a much more conservative bent. I think we'll have to see, and then we'll have to see what happens in the presidential election. We've been voting for quite a while here in New York, and I know you've just begun to vote in Texas. So I
Yes.
think the most important thing we can all do is vote and realize that what we vote will matter in terms of healthcare.
Excellent. Um, I'm seeing that we're pretty close to end time. Let me see if I have. I have a lot of thank yous from everyone in the community that are coming in. And we again so appreciate your time being with us, and we hope that as we come out of this, maybe you can come back to El Paso and we can go and enjoy some
Love it.
wonderful cuisine.
I love it. I will be there in a heartbeat, and I look forward to listening to my Meadows colleagues.
Wonderful. We hope you'll stay on and listen in, and we'll continue with our show. Thanks again for everything that you've done to help present this information to us today.
Thank you.
And now, as you all have been told before, if you're having, I'm noticing a couple of messages coming through talking about the system, and sometimes your Wi-Fi or things like that can slow things down. You can please try and refresh your screen, or sometimes even restart. If you're having trouble, contact technical support at 773-645-4877. We'll continue with our show, and we have some wonderful presenters next. I want to speak really quickly about the importance of a benchmark report. When the 2014 when the consortium came together in 2014, they really looked carefully at what do we have, what kind of data do we have available, where are gaps, what can we best do to make change for our community and really make some lasting improvements. And so at that time, Tri-West Group came in and helped in an 8-month event, went through and developed a report for us that became a lasting benchmark for the community. What we are engaged in now as a community, the El Paso community, is this massive attempt to redo that and go back and understand better where we have been, where we are today, and where we're going. And to do that, you need some great thought leadership, some folks, not just from our community, but also maybe some external folks to help inform how we best come together and put this point of reference document for planning and future reference going forward. And today we have 2 of the team leads for this project. And so what we have is Melissa Rowan. She is the Executive Vice President of Policy Implementation, and she brings a real-world focus to the Institute's health systems. And Melissa has been a partner at Wenson Rowan, a healthcare policy consulting firm. She founded in Austin, and she worked in and around Texas and nationally on behavioral health and health systems for over 25 years, focusing on broad healthcare issues, managed care, behavioral health. And after consulting with the Institute, she took on an expanded role as a senior fellow. And in April 2019, Melissa worked on a range of projects, primary focus on service expansion and quality improvement in real-world settings and healthcare financing. She previously served as a healthcare policy director for the Texas Council of Community Centers in Austin, working closely with 39 community mental health centers across the state on innovation and design of behavioral health programs for adults and children. She has also been appointed to the boards of the TMF, Health Quality Institute, and LifeWorks, as well as serving as vice chair of the Health and Human Services Commission Behavioral Health Integration Advisory Committee. She earned her Master's of Social Work from the University of Texas at Austin and an MBA from Concordia University. We also have John Petrila, and he is an attorney with 40 years experience in the mental health law and policy arena. Before joining the Meadows Mental Health Policy Institute, he chaired the Department of Health and Public Policy at the University of South Florida College of Public Health. Prior to that, he chaired the Department of Mental Health Law and Policy at the Florida Mental Health Institute, where he built a department that worked extensively with administrative data to inform policy at the county and state level. He also was the first director of forensic services in the Missouri Department of Mental Health and was chief counsel and deputy commissioner of the New York State Health Office of Mental Health. He received his law degree and an advanced degree in mental health law from the University of Virginia School of Law. He is a national expert on data sharing and wrote a chapter on confidentiality for the 1999 Surgeon General's Report on Mental Health. He is a member of the John and Catherine MacArthur Foundation Research Network and mandated community treatment, and is a past president of the International Association of Forensic Mental Health Services. In 2011, he was named a Fulbright Scholar to the Netherlands and taught and conducted research at Forensic Psychology program in Maastricht University. Melissa, John, tell us what you're learning about our community.
Thank you, Enrique. Can everyone hear me? Okay, it's always strange to watch your cell phone video and see no one in the audience. And it's never good to follow Linda in any presentation. So we're happy to be here this afternoon or this morning to talk to you about the 2020 El Paso Behavioral Health System Assessment that the Institute is conducting. We'll talk a little bit about the project and some progress to date. We are in the middle of the assessment, so we aren't here today to talk about findings, but talk to you kind of about where we are and kind of how we're working through this process with the community and some emerging themes. So if you're not familiar with the Institute, I think the one thing I'd say is I think when the Institute was started, it had a bold vision to envision Texas to be the national leader in treating people with mental health needs. If you've been in behavioral health in Texas for a long time, like many of us have, 25 years ago, that was not a vision anyone had. And really, it's been the last 10 years, I think, where we've seen the investment in mental health and the innovation in a way that really gives Texas a lot to be proud of and a real position in the national stage. At the Institute, we really look at how are local systems working and what are the gaps that need to be filled and what are the policy barriers that are keeping local systems from being able to really innovate and provide best quality and treatment for people with behavioral health needs. And we link that to the work that we do in state policy so that the state policy supports what you want to do locally. And so this project is really an opportunity for us as an institute to learn more about the progress that's been made and where you've run into barriers and how we can have a policy agenda at the state level to really support the work here. This is the primary work that we're doing for the assessment in 2020. The first is, you've heard other people talk about today, is closing the loop from the 2014 assessment that was done in El Paso. And so I think both the foundation and the consortium had a real vision, not just to implement a plan, but really to watch to see how you've progressed, to celebrate the progress, and to also look for where do you go next. Because we all know that there's always opportunity for quality improvement in any healthcare system. And I think that the 2020 assessment will both celebrate what you've done since 2014 and look for where does it make sense to go next. We're specifically focusing in 3 areas. In addition to the progress from 2014, we're focusing on the crisis system and looking at an improvement opportunity and analysis there. What does the current system look like? And what are the gaps where if you're looking for opportunities to build over the next 5 years, where is it that you would go next? I think when you look at that long list of accomplishments that Tracy discussed in the beginning, a lot of those have been in the crisis system. We've seen accomplishments there. So how do you prepare for what you're looking for in the future? Because your plan, I think, in a lot of ways helped you to be ready for when opportunities presented themselves. And so we want to help you in thinking through, what does that look like? What are the opportunities you're looking for going forward? We'll also be looking at the children's mental health strategy with a focus on high-risk children, including those in the juvenile justice system, and what are the opportunities for service expansion and innovation in that space. And then the last piece of the assessment is looking at an overall access to services, an evaluation of your current capacity, who's accessing the services that are available, and what's the utilization of those services. So who's using them and how often are they being used? Do you have the capacity for the need in the community? So that will be a large portion of a data section that we intend to have for the consortium to be able to really have a data-driven approach to how you continue to move forward. I wanted to acknowledge two things. First, I want to acknowledge there's a team at the Institute that's working diligently on this project. John and I get to be the faces with you today, but there's an amazing group at the Institute that's working with people in your community as we do the assessment. In addition to our team, we have a El Paso Systems Assessment Implementation Group, which we have been calling the SAGE, which has been a group of individuals that have come together and provide guidance throughout our assessment process. We meet with them on a monthly basis. So you can see the names here on the first slide. I'm not going to read everyone's name, but there's 2 slides with names to capture everyone in the group. So you can see the members here and then the rest of the members on this slide. This is an opportunity, and it's been so beneficial to our process, because as we have questions, as we are documenting how things are working and what is happening in El Paso, we have a place to take that every month and get feedback and get people's insight into where can we go for data that we're looking for. Do we understand things appropriately? Because we don't live in El Paso, and we know that. And so this is our team of people from El Paso that are really helping to shape this project as it moves forward. So you have a sense of where we are. We started in June of 2020. And then we met with the community and have been meeting with the SAGE group and the foundation staff. We did a work plan in July, and then our first formal deliverable will be at the end of October, which is an initial qualitative data summary, which will really feed into that access to care section I was talking about. In November, we'll provide a summary of draft findings and recommendations and a draft final report at the end of December, with a final report in April. So when some of the things that we talk about here today are really just about our experience in the process, we haven't come to a place where we have a set of draft findings and recommendations, but we're working through that process now. So John's going to talk some about our progress to date and some about prevalence data. John, do you want to go ahead?
Sure. It's a great pleasure to be here. And Melissa, I wonder, can you bring up the next slide? Do you have that control of that?
Sure.
Thank you. I think just sort of a quick preface that this consortium really illustrates sort of the specialness of El Paso, because you've got, and it also illustrates the Institute's work very well. So you start with this national perspective that there's no one in the country better equipped to give than Linda, who also, she's declared, has El Paso as one of her favorite sort of places, given her sort of breadth of work across the entire country. We're going to talk about the local assessment, and as Melissa said, not specifically talk about findings. I'm going to give a couple of sort of preliminary thoughts just for you all to get a sense of sort of how we approach this work. And then Andy will talk about what's sort of may unfurl in the legislative session. So again, I think this illustrates sort of the power of the leadership group in El Paso, the interest across the community generally, and also merges nicely or fits nicely with what's going on at a national level and a state level. So hopefully some of those connections will be obvious to you all through the day, and very much grateful to Enrique, Tracy, and other colleagues for the opportunity to do this. We've conducted, just want to give you a sense of sort of how we've approached this for those not involved intimately with the assessment, though many of you on this call have likely been interviewed. When we first talked with Enrique and folks, the thought was, or we were told, if you interview 30 folks, that'll be great. And as you can see, we've interviewed 100 people, and we anticipate interviewing more. It's not to sort of load on interviews that aren't necessary, but as you get into a community like El Paso, and particularly a community that, as Linda said, and as Enrique and Tracy have noted, has decided to kind of reassess itself and see what progress has been made, how has the world changed, kind of where the future might lie, that you've got to talk to folks from a wide variety of backgrounds and interests. And so we've talked to folks from virtually every system, and we very much appreciate how accessible people have been, how cooperative people have been, and how candid people have been. So just a thanks to all of you on this call who've participated in these interviews today. If I could have the next slide. We've also presented to several community groups. One of the things that you have in El Paso is a robust kind of leadership group, and sort of not quite a governance process, but a leadership forums where people can gather together and talk about priorities, talk about progress, talk about gaps on a continuous basis. And just by way of contrast, one of the things that we have seen in at least some communities where we've done assessments is that this sort of internal community structure, this investment by leaders from across the spectrum, really doesn't exist, or it's in very embryonic form. And so El Paso is ahead of the curve in that sense on this issue, and it's an important issue. And, we hear in interviews, as you do everywhere, well, it'd be better if so-and-so did something better, we could do this, we could do that a little bit differently. But that's just part of the kind of exchange of ideas when you get folks from different backgrounds and different roles together. And so I think the commitment to local leadership, the commitment to inclusion, while we may have suggestions over time for, either some improvement or you might try this differently or you might try the other thing, there's a commitment in El Paso to community leadership and inclusion in that leadership that is really quite remarkable. And again, I think a credit to the community, because this is not a recent thing. And to a large extent, the original assessment that was done in 2014 was stimulated by a leadership group that in many communities simply didn't exist. So I want to acknowledge that. And we've used this as an iterative process as well, because there have been places where we've done assessments where getting kind of stakeholders engaged in sort of testing ideas in terms of kind of, well, that doesn't seem right to us, that seems right, you might think more differently about that sometimes is hard to do. So in El Paso, we've had multiple opportunities to present to community groups. And again, we very much appreciate that and want to acknowledge that in many respects, you are ahead of a good number of communities in Texas and also nationally. If I could have the next slide. We've also engaged in data collection in a variety of ways. One of the things you'll see when you get our report in the end, and those who've been involved in some of the early briefings already know, we use a good amount of data that's generated by health providers and maintained in Texas repositories. And so that's sort of archival data that we access. And then we've also talked with a good number of folks and to gather kind of local data. And some of that's qualitative, the 100 interviews we've done. Some of that is locally generated, which does not necessarily show up in Texas more general repositories. And so that's been very helpful in this as well. And, I want to, as another area where I think El Paso is ahead of a good number of places in Texas, is you've got an HIE, a Health Information Exchange, that actually participates actively in trying to help the community sort out utilization across systems and things like that. And that's not always the case. So again, just want to acknowledge that as an asset among many, that is something that you have locally that not every community does. And I think that's something to continue to try to rely on as we go forward. Next slide. We've also done a lot of work, and this is where the iterative process that Melissa and I have described has paid off, and where the interest of leaders and community members has paid off, where sort of the point of entry to the system, and Linda alluded to this a bit, is often in crisis, right? And so it may or may be more so with mental health than other diseases, but a crisis is often the entry point for entry to the health system. We have historically, for lots of reasons, over-relied on law enforcement as the sort of decision point and point of initial response to mental health crises versus other crises of healthcare. But sort of how that system works, where people enter care in crisis, is an important sort of factor, and it varies by community. And some of those entry points are formal. We could all probably, the 118 folks on this call, most people would write down emergency rooms as a point of entry. Not everyone would necessarily write down kind of support hotlines. And so we've done a lot of work trying to understand and map out the crisis system. And when I say system, it really is lots of different points of entry where people can enter or find themselves entering care in a crisis. And so we've tried to identify, track, and will map the formal points of entry like emergency rooms, but also acknowledge there are other ways people enter services in crisis. And we've talked again with the group that we, as Melissa said, we meet with monthly. People have given good feedback on this because we wanted to describe it accurately, but also acknowledge kind of that it's not just someone picks you up and takes you to emergency room. And so we're mapping that as well. And I think one of the things you've done work, as I think Tracy said at the beginning, or Linda, on CIT training, you've done that in a very robust way. You've created specialty courts. But sort of where we're moving, I think, as a field is to a much more of a medically facing crisis response. And so this mapping will help identify points where we can rely less as appropriate on law enforcement, more on paramedics and folks as we do in other health crises. And so that's been a part of our work. I think the conclusion we've drawn, and again, as Melissa said, this is early days, and when Enrique asked us to present, we said we were not going to present formal findings. But again, it appears to us that there is a more robust sort of crisis response in El Paso than in some other communities we've looked at in Texas. It doesn't mean it's perfect. It doesn't mean it can't be improved. It doesn't mean it can't be better integrated. But this is an area, again, where I think El Paso has worked hard to try to really think through crisis response. And so I want to emphasize both the importance of mapping that system, the cooperation and help of local leaders in assuring that how we map that is as accurate as it can be, and also it's one of the core deliverables in this work. And so we'll be coming back to that. If I could have the next slide, please. So talk a bit about prevalence data. If we go to the next slide. One of the things we were asked to do is talk about access to care. And one of the things that is important as a foundation to understanding access is just sorting out how people use services. What do the prevalence data look like? Do they change over time? And so we've got an enormous amount of data on this. And I just want to give you a bit of sort of information about how we do that, but also a couple of things that appear to be the case so far. We look at emergency room use. We look at hospital use. One of the things that we find in many communities is that for psychiatric hospitalization, people are shunted around the state. As I'll say in a couple of minutes, that's less so in El Paso, which is a good thing. We also want to look at, and we'll look at, demographic changes, comorbid conditions, and things like that. So one of the first thing is to map out sort of just numbers of folks with serious mental illness, other types of mental health issues, kids with emotional disorders, what have you. And then we've looked at these other issues as well. If I could have the next slide. And so what we find when we look at prevalence, and for those of you who are, there's probably out of 120 people, at least a couple of you who live for stats, you'll find enormous number of appendices at the back of our report when we give it to you, is that about 60,000 kids, children and youth in El Paso County in 2018 with mental health needs, and a relatively smaller number, about 10,000 with serious emotional disorders. We don't operate or come at this issue like, government often has had to do to allocate resources. Government has often had to focus on those most in need, those with most severe illnesses. And certainly Linda would recall, as I do from our days together in New York, where that was a tremendous focus. But we do try to give you some sense of how many folks have serious needs versus needs that can be met, particularly in primary care. This is important because for most kids, most adults, mental health needs can be met in primary care settings. And so that's part of what we'll try to lay out in our report. If I go to the next slide. Same with adults. Again, poverty, a major issue in El Paso, as is the case in many communities in Texas. As Linda said, poverty is the leading social determinant, right? If you're poor, often you have more problems with access to care. But we'll talk about the number of folks with serious mental illness, about 25,000. One of the interesting things is we look at the Texas demographers' projections going forward to 2050, and it appears that those projections show a significant increase in population of older adults in El Paso. And so that's going to have some impact on how you think about services going forward. Less growth among younger people, more growth among older people. And so there'll be some of that will be captured in our report. Next slide. We also look at emergency department use, psychiatric visits. This again will give you a sense, and we'll have much more detail about how many folks had a primary diagnosis for psych and a secondary diagnosis for psych in the emergency room. As Linda said, and as all of you know, we now talk about integrated care in a much more concrete, realistic way than we used to. So we look at primary psych diagnosis, but also secondary associated with general health issues. And one of the things that is true in, again, the emergency room is often a point of entry to hospital care. One of the things that is interesting about El Paso and different than the last major assessments we've done is that it appears that fewer than 5% of people from El Paso go elsewhere in the state for hospital care. There's communities we've looked at where as many as 40% of people from a community who are hospitalized for inpatient care go somewhere else outside the community. So you've done a tremendous job, it appears, of keeping folks local for their hospital needs. And in fact, about 15% of the admissions to your psych hospital beds come from other communities. And so that's something we'll talk about as well in our assessment as we get to the findings, but something worth noting about El Paso as well. So go to the next slide. And Melissa, I believe this goes back to you at this point.
Yeah, thank you, John. So I'm going to talk a little bit about emerging themes, some of the things that we are seeing. John's mentioned some of that even in the prevalence data. So we're still analyzing the local system of care, but we do know progress has been made since 2014, a lot of progress, and that opportunities for building on that progress exist. So I think one of the things that we often have a hard time doing in the mental health field is stopping and saying, things are moving in the direction we want them to move. And so, but we always have opportunity to continue to improve on that. COVID-19, as has been discussed in earlier presentations, has changed the healthcare service delivery system and significantly increased the use of telemedicine and telehealth. So we have not really had a report at this point that has that where the entire report has been in the time of COVID. It changed the way we've done our work. It changes the way that healthcare is being delivered in your community. The use of telemedicine and telehealth, as Linda talked about, has really been a significant improvement in many ways for access, but there's also some providers who've had a harder time with that, or as we learn more about who does well with telehealth, mental health services, and who doesn't, that helps us to think about how to do this when we're post-COVID, and how do we keep the gains that we've had on access. We've heard from a lot of providers that the rate of people not coming in for their appointments has significantly decreased. So right there, that's opening up access to more people. We're not holding appointments that aren't being filled. And it helps people to deal with things like transportation, childcare, many of the things that people struggle with that keep them from getting to their scheduled appointments. We've seen telehealth really make a difference in that. And so we'll be talking about that in our report. I know in Tracy's presentation and in some discussions with some of the nonprofit organizations in town, COVID-19 has been difficult on those organizations from a financing standpoint. And so there's also operational issues and financing issues that COVID-19 has brought about that we'll be talking about. We've seen El Paso take advantage of new programs for mental health services to children in primary care and in schools. The CPAN and TCHAP programs being operated by the medical school. I think that this opportunity really helps. When John showed the slide about the number of children with mild, moderate, and severe mental health issues, a lot of times kids are going into specialty care because that's where people assume you should get your mental health services, when really primary care physicians are the place where most mental health services can be delivered with support. And so the CPAN program provides that psychiatric consultation to primary care offices so that they can ask a specialist questions so that they can feel comfortable in delivering mental health services for many children in the community, which then opens up space to those higher end specialty care for kids that are at higher risk or having serious emotional disturbance. So we see this as an opportunity to really maximize the use of the system by getting people into the best place for what it is that they're trying to work through. And the TCHAP program is in schools, which is it's going to be working alongside many of your existing mental health partnerships. El Paso school districts have really done a lot of work around mental health. And so we see this as a further enhancement of the work that's been done. One of the other things is evidence-based treatment for youth in El Paso. We're seeing a lot of that in the juvenile justice system in particular, and a real strength in the way that the juvenile justice system works in El Paso. But some of those evidence-based treatment programs, like one of the programs, MST, multi-systemic therapy, is a project between the El Paso Probation Department and Emergence Health Network, but kids have to be in the juvenile justice system to access that. And that's really a best practice service for high need kids. And so we'll be talking some about how do we take some of that innovation that's in the juvenile justice system and get that spread broader in the community before kids access that system. The crisis system has had several components added since 2014. This has been a real area where there has been focused effort in the community, and you can see the results of that. We talked about the crisis intervention team. There's also the coordinated specialty care program for youth and young adults experiencing their first episode of psychosis. So that is a best practice program for those young adults. And that's something new since 2014. So there's a lot of high-end services that have been created. But as in many communities, what we've heard in some of our conversations in those interviews is that people in the community are not always sure what exists or how to access that. And so we'll be, we're working on that, on the crisis mapping, in order to make a clear understanding for people who read the report on what's available and how to access that. And then we'll be also talking more about, how to leverage that as you move forward. And then the last emerging theme that I'll mention is that El Paso, and I think the Behavioral Health Consortium is the perfect example as we're here today having these conversations, is that leaders across your health, education, and justice systems have really come together since 2014 to collaborate on how to improve the system of care for people in your community. It's very impressive, the work that's been done and is still being done today. We do have stakeholders who have suggested that more can be done, which I think is always the case, is that, we continually grow and improve what we're doing. The fact that we've had so many people who wanted to talk to us about behavioral health service delivery in your community is really impressive. And so we'll be talking in a report about the leadership efforts since 2014, and then what does that look like as you move forward. Enrique, do you want to pop onto the screen and maybe we can take some questions or have some discussion if folks have anything?
Right. Can you hear me?
I can hear you.
Yes.
Should we see you or just hear you?
I think I'll be the voice from afar. How about that? Okay. I can even use my radio voice. How about that?
Do other people hear you, or is it just me and John?
I'm sure others can hear me, and if they can't, well, I'm very sorry about that. But okay. Melissa, John, Melissa, thank you so much for this overview. We know that there's a lot more to do, and I want to take this couple of minutes here to really recognize that you all have been very adaptable. These conditions changed in a heartbeat. We were planning this system assessment, and as an intensive 10-month review, and you all have been able to get a lot accomplished even with the COVID conditions and the stay-at-home orders. You've been able to adapt and move forward and get us the data that we're looking for. We're looking forward to the full report, and this is something that will be a public document. It'll be an asset for our community. And so we appreciate everything that the Meadows Mental Health Policy Institute is doing for our community. And with that, I'm going to take I know we have a little bit of time, so I'll take one or two questions here. And one of them that I've got right now, so with regard to telehealth, do you think the changes with telehealth and COVID-19 will bounce back once this health emergency ends? Will we go back to a form of that? Or how do you see that developing as the coming years go, now that we're learning more about these technologies?
I'll take that one, John. I think that with telehealth, and I know Andy's going to talk more about this as part of our legislative agenda. During COVID, there have been many changes to both the regulatory and reimbursement allowances for telehealth that made it much easier for providers and financially viable for providers to offer telehealth broadly. We've been using telehealth, particularly in rural Texas, for behavioral health services, but there's still been a lot of resistance and inertia in actually moving forward on telehealth. And then really overnight, it just changed. I mean, within 2 weeks, behavioral health providers across the state had gone virtual. And the benefit of that is during very difficult times, people are continuing to get their behavioral health services. But we have to make sure that the regulatory and reimbursement changes that allowed that to happen continue. I think there'll be a lot of discussion. One of the things that's been allowed is telephone audio only services. So you don't have to have video for telehealth, which wasn't allowed before, but in this time of the crisis, that's been allowed. Whether or not that will be allowed to continue, I think we've got to be able to bring together our data to show the outcomes that people have had with those services. And so we're going to be really pushing that these things, and I think a lot of providers are going to be making sure that the legislature understands how important these changes have been and the benefits of that. I think patients receiving telehealth services across the board in all specialties have really engaged with that as a much simpler way to get many of their healthcare needs met with good quality services. And so I think from that standpoint, there'll still be a lot of people pushing that those continue. The reimbursement part of it is going to be critical, particularly in commercial insurance. A lot of times telehealth is paid for at a lower rate than an in-person visit, which is part of why we had a lot of in-person visits and a lot less telehealth before the COVID emergency. So I think there's a lot of progress that's been made. I don't think we will go back to where we were before. The question will be, what will be permanent in the way that we're allowed to provide it and how you get paid for it going forward. And those questions at this point are unanswered because they continue to renew those options, but under the public health emergency declaration.
Thanks, Melissa. And John, you and I met when Meadows was just an idea. And so it's exciting to see here and in Texas. We know that all the work that you've done. What's it like being here in Texas rather than at the national level? And well, I'll stop there. What's it like? How's Texas for you?
I think Texas is terrific. It's been 4 years at the Institute. And as you said, Enrique, you and I met as the foundation, Meadows Foundation, was trying to decide to invest heavily in mental health or not with what became the Institute. Even when I was in Florida at a mental health institute there, Texas was always, for example, in the justice area, sort of ahead of where the country was. So Texas was attuned to mental health issues among correctional populations in a way that most states weren't. It was a leader in information sharing. And so I tended to, in my work, which focused heavily on justice-related issues, back to Florida, back even to Missouri when I was forensic director there 1,000 years ago, Texas was always been kind of a leader in this field. And so when you get here, you find that both my assumptions about Texas leadership were true. Second, that the legislature has invested probably more heavily in mental health, both financially, but also in terms of creating innovative program structures than any legislature in the country. Remember, we came through a decade in sort of the middle of the, from 2005 or 2006 through 2012 or 14, where states cut heavily in terms of general revenue commitments and Medicaid commitments to mental health. There were states like Virginia that cut up to 20% of its budget. And so it's been very different in Texas. So that's a change or a difference that I appreciate very much. And the third is really local leadership. And again, this is not to flatter folks on this call, but El Paso is a tremendous example of local leaders engaged kind of in bipartisan ways to try to make things better for folks with mental illness. And so, one of the big changes, and Linda talked about this in her talk, was sort of mental health, mental illness out of the closet in a sense. And that's a huge change in my lifetime. It's a huge change in the lifetime of many folks on this call. And I think Texas, you have local leaders in diverse communities across the state who've embraced this as an issue in ways that are quite unique. And again, I think way ahead of where many communities in the United States are. So relatively long-winded answer, but it's been terrific. And I could not be happier to be here. So
wonderful. I really appreciate you both being here with us and providing us this information. Again, we're looking forward to the report. And we also know that you all are readily available at the Meadows Mental Health Policy Institute, and want to recognize that to the community, and that as questions come up and things, we want to try and keep connected, because you all are on the cusp of the work that's being done around mental health improvement in Texas. So thanks again for being here with us. And we look forward to seeing you in our community very soon.
Thank you, Enrique.
Thanks, Enrique. It's a pleasure. And thanks everybody else on the call. Thanks so much.
So we're at the stage where I want to just recognize again our community. And I know there's quite a few people on the conversation today, and I really appreciate that. By the way, my name is Enrique Mata, in case you all didn't know, and I'm the one who's been typing some things up there about questions. We have quite a few questions that have come in, and we want to try and get those responded to. So there's an area with a link where you can go to a website that we've got that's being developed for the El Paso Behavioral Health Consortium, and we will post as much information as possible out there with regard to this event. If there's a recording, kind of stuff, it'll be posted to that site. So you're welcome to contact me, or you're welcome to go to that site and look for that information. It should be posted probably tomorrow after the event is completed. At this time, what I want to do is also recognize that in the years past, we've done something unique. It's very difficult to get MOUs signed with organizations because of the legal ramifications and all that stuff. Folks just, it's hard to vet that. But what we did do in our community was recognize through our community leaders on video that the true diversity and how much folks are collaborating with each other. And so these next few videos that we've got as we go into our break, when we do want you to take a break, we do want you to, take a bathroom break or get some water, etc., because the next presentation is going to be great. But during this time, we have some videos that'll be running, and they are reflections. They're videos from a couple of years ago, but they are certainly still relevant, and they do recognize quite a few folks in our community who are showing how much collaboration is going on. And we want to thank everyone again for all that collaboration. We certainly are going to continue to need it even into 2021 and beyond, because we don't know the ramifications of what this COVID-19 pandemic is going to cause for our mental health and emotional well-being over the long term. So I'm going to close this section right now and take us into the break. And we look forward to seeing you as soon as we get back, which will be in 10 minutes.
The Family Leadership Council is all the child-serving agencies in town having come together to look at the gaps in our mental health system, specifically relating to children and adolescents.
It's creating access to the services that are out there. I think for many years we existed and talked to each other, so didn't coordinate services as well.
A lot of good relationships have been built out of meeting and networking and building that trust between agencies.
So we have 5 different work groups that have stemmed out of the Family Leadership Council. Each work group was created around the different goals that the group established. So some examples are mental health in schools, increasing collaborations, education, and foster care.
Biggest hurdle that I'm looking at and helping to work collaboratively with Child Protective Services in helping develop more foster homes for teenage or for adolescent that are in the community that are needing foster care.
One of the particular projects that we're working on right now as a community collaborative is reaching teens, which is an evidence-informed toolkit. It's a model of care for serving youth, adolescents, and their families.
And then the collaborative or the initiative that has just started is that bringing the educational institutions together, the ISDs, to be able to start talking and identifying those issues that they have with respect to educating children with mental health issues and special needs. And I think that's hugely important because now there's an opportunity for the education systems in our community to learn of and work with those social serving agencies that exist and to make sure that we're eliminating those silos that exist and that the best interest of the children in our community is served, because now they can be served by all agencies who are capable of meeting the needs of that family and the child.
It's been a very exciting journey to see how we've all gotten to know each other, how we've gotten to know our own community better, and how we are now actively in the phase of really concretizing and really executing some strategies that we are very hopeful is going to help improve the lives of kids in our community.
So the Integration Council has 5 goals that they we've set for ourselves for the next several years, and ranging from the integration of mental health care to primary care to substance abuse care to individuals who have both a substance abuse problem and a mental illness problem, and also increasing the manpower in order of folks that can treat these problems.
There's several systems, services, and support services that are out in the community, but we really want to collaborate with one another to ensure that it's focused on recovery, because it's not just about getting a service and then leaving. It's about a lifelong recovery and living a healthy lifestyle, and how are we contributing to that, and how is the community contributing to that. So what we did was working with integration councils to say that includes health, primary care, as well as mental health and substance use disorders. How do we help a person maintain a healthy lifestyle?
Well, integrated care requires a sufficient workforce, of course, but more than that, it requires a workforce with the right training and interprofessional education to do that job. And to that end, the Integration Leadership Council is working on better data than what we have right now. We need good data about what the specific needs are. We already have some great programs in the area, but we have a pipeline issue in that some of the people who have finished their didactic training have trouble getting the necessary supervised experience to achieve independent licensure. And we want to attack that pipeline when it comes to, say, internships for licensed professional counselors, or supervised experience for licensed clinical social workers, residencies for psychiatrists, or postdocs for psychologists.
So one of the initiatives is to really join forces and to see how can we come up with a common vision that we can address those issues.
We have to bring the community together to do those things. And, I cannot do it alone working with emergence. El Paso Behavioral Health can't do it alone. We're working in the area that they're working in with inpatients. So I really appreciate that they're bringing together their expertise and their passion to drive what we need here in El Paso for our population. Because, when someone looks up El Paso, I want them to know that the mental health temperature here is actually, it's okay. That we're doing what we need to do and we're taking care of our people.
Justice Leadership Council is responsible to look at the entire system of criminal justice here in El Paso as it relates to how we interact and how we deal with people suffering from mental illness that enter into that system.
The reality is some crimes are more dangerous than others. Some are violent and some are not. And so when we're sending people away for long periods of time because they're having problems, because when they're not on their meds, they're stealing a lot. But we're incarcerating those people when really what we need is maybe, because they're in the system, we can use that as an option to get them on probation, to order some kind of supervision that requires them to attend services, take their medication, receive counseling, therapy, etc.
It is an issue that needs a focus and to be addressed. We don't have resources focused on that area, and so individuals often may go to inappropriate systems. So that might be the jail, hospital emergency rooms, and inpatient psychiatric facilities, which is not where they can get the care that they need.
One of the most important ones deals with how we as a community take that first initial call to 911 and decide whether it needs to be a law enforcement response or a response of some medical professional.
So Emergence Health Network is a key partner and collaborative stakeholder with the City of El Paso and the El Paso Police Department in the development of our Crisis Intervention Team, CIT. And so that team will be able to deploy, provide an assessment, do an intervention, and then get them to the right system of care at the right time.
We want to create an evidence-based court. And what that means really is that it's based on research, it's based on data. We're trying to get data about who's coming in, what are the diagnoses that people, I can tell you anecdotally, I see a lot of folks with bipolar disorder. I see quite a few schizophrenics. But there's a whole variety of other mental health issues, some more serious than others, some with more dire needs, require more commitment, more resources. But the results of what they result in terms of the crime that they result in, really vary.
As a society, we have to recognize that it's much more cost effective and much more humane to deal with people outside jail in a compassionate way that will protect society and protect that individual into the future.
You know, we're going to provide them mental health services when they're in jail. Why can't we do that when they're out of jail? Maybe be more productive and stabilized.
And we're back. I hope you had an opportunity to step away, get some water, take a breathing exercise, and then you're ready to come back and listen to this wonderful presenter. It's truly an honor to be introducing our next speaker. He was one of the architects of the 2014 El Paso Behavioral Health System Assessment, and also one of the architects of what would become the Meadows Mental Health Policy Institute. And now, as the president, chief executive officer of the Meadows Policy Institute, he's built a dream team of advisors, a tremendous catalyst for mental health policy in Texas, and just an overall wonderful technical support center for the state and for that is also helping our community. Andy Keller is the, and I'll say again, President and Chief Executive Officer, and Linda Perryman Evans, Presidential Chair of the Meadows Mental Health Policy Institute. It's a Texas-based nonprofit that provides nonpartisan policy and program research, development, and advice to state and local leaders. Oh, I can see you there, Jen. I haven't seen you on the screen. My apologies. So let me continue with this because I think it's important for people to know this. So it's a Texas-based nonprofit and provides nonpartisan policy and program research, development, and advice to state and local leaders towards a single goal: improving mental health care delivery in Texas. Andy is a licensed psychologist with more than 20 years of experience in behavioral health policy, financing, and best practices. His work is centered on helping state and local health systems implement evidence-based and innovative care, as well as helping local, state, and state governments develop the regulatory and financial frameworks to support them. Prior to moving full-time into the policy work, Andy was managing partner for 15 years at a national behavioral health management consulting firm, where he focused on health financing and system improvement. Before that, he worked in Colorado with a leading Medicaid HMO and local community mental health system, where he directed and led a range of community-based management programs. Andy, it's great to have you in El Paso virtually. We hope to see you again soon in person, but for now, it's good to have you here. How are you doing?
I'm well, Enrique. Great to be here, and it's always an honor to be here. And I feel like we're with friends and people we've been working with for a long time. Whenever we're doing stuff in El Paso, so thanks for that kind introduction. It's hard to follow Linda, Melissa, and John. So hopefully people still have some bandwidth left to take in information, because this has been an amazing morning of information y'all have organized. So.
Well, in many ways, I think your presentation is going to be a great segue into thinking about where we go as far as the legislative session goes. I was part of the Engage and Excel event and participated. It was a great event, by the way. And I heard you and Ford Price and Representative Moody talk about some of the things that are going on. I'm hoping that's the information that you'll share with us today, and maybe more. So I will let you have the stage.
Absolutely. Thanks, Enrique. I'll do my best. And I'll try to save some time for questions. I've got a fair amount to go over, but we should have 15 minutes for questions. So please ask questions, ask hard questions. Though I may not know anything about the Supreme Court, but I'm willing to take whatever question you have. It's great to be here in El Paso today. And, it is a place, El Paso. Please, actually, if I can see my own slides here, let me see if I can do that. Yeah, I can do it myself. So it's great to be here in El Paso today because Enrique talked about that 2014 assessment. That was the year the Institute launched. And this was the first community where we were kind of working in depth and trying to understand what was going on then. And, El Paso for me too is a place where, when I was with my former organization, TriWest, the first big project we had in Texas was here back in 2001. And I mean, we've been in this community a long time. I've got friends here, and it's been fun to get to know both system leaders as well as individual agencies. We've had an opportunity to work with many of you, both on individual projects as well as sort of more systemic projects. And the thing I love is that you guys get things done. Also, El Paso feels the most to me like where I grew up. I grew up in Eastern Washington State, which is sort of high mountain desert, and it's actually a similar climate. So I feel kind of at home when I'm getting to be with y'all, and I wish I could be there in person today. So, Melissa and John already talked about this slide, but, we really do work with the synergy between the state and local level. If we're not in communities seeing what's really happening for y'all, then we don't do effective work in the state capitol. So I'm going to talk about the work in the state capitol we and others are doing. We do much of that alongside y'all. You all are very actively engaged there as individual entities as well as part of associations. But, like El Paso, like back in that 2014 assessment, I had never really done much of the justice system before. I had colleagues that did that. So the very first time I visited a jail and looked at a jail mental health program was in 2013 as part of that assessment. I remember talking to Sheriff Wiles back then about, it was great to see him on the video here a minute ago, just about, some of the things going on. And things have changed. Like that wasn't like, just a few years ago. That was like 6 years ago, almost 7 really, when we were doing the data collection. So things have changed. So CIT was like state of the art then. Now it's multidisciplinary response teams where paramedics are leading. So, we're continuing to push the envelope as a industry, and working alongside you all has been great for informing our work at the state level. And then vice versa, we can come back and talk about the state programs we had the honor to participate in, and then be able to work with you all on that and trying to help you exploit and take advantage of that, which is a good thing. Like, and it was purposely designed that way. If it sounds like, wow, they like design programs and help people implement them, it sounds like they're going to have work forever. We probably will. And the design was on purpose. We designed it that way. In fact, Enrique was a big part of the design of this organization. Paso del Norte Health Foundation from the beginning was on the design committee for the Institute. Back during 2012, 2013, Sharon Butterworth, others have really, Tracy, I met Tracy for the first time back in 2013. So it's just, we really appreciate it. And so, when we talk about what we've been able to accomplish in the Texas legislature over the last 2 sessions, both in terms of funding, but also in terms of priorities. I mean, we've passed 42 of our legislative priorities the last 2 sessions, many of those developed in collaboration with folks like y'all. I actually changed it to 43 because we were able to get an additional one passed after the session by a voluntary change in their procedures by the Texas Education Agency that we had thought we might have to force statutorily, but they agreed during the session that they would just make the change. So that bill didn't need to go forward. It was actually a budget writer. But anyway, that work is important, and it's stuff that we would really do want your guidance on, because this is going to be a different session this year. This is, this is a different world we live in. But, the baseline world of how we treat mental health in this country still looks, unfortunately, a lot like this systemic map that we see here. Like, too much, we wait until the point of crisis to detect care. Care continues to be fragmented. I mean, Melissa talked about, how you can get some great intensive evidence-based services. And, you all have evidence-based services across your continuum. You have them in primary care. You have them in specialty clinics, trauma-focused care or whatnot. But the intensive evidence-based services that you have, are really, particularly for youth, with more severe behavioral acting out, you have to get arrested first. Well, that's a fragmented system. For other healthcare conditions, you go to the doctor, you don't go to law enforcement. And unfortunately, law enforcement is still the point of contact. It's how our system is designed in a statutory way still. We're the only state in the country. We're the only people other than a judge who can order you into involuntary psychiatric care in Texas are peace officers. So the other 2 states I'm licensed in, Michigan and Colorado, I could order you into a psychiatric facility, but I can't in Texas. I have to go find a police officer friend and try to get them to order you into it. So that's still the case we have. Too many people dying of suicide, too many people dying of substance use. And, that was the epidemic, the deaths of despair Linda talked about before the pandemic. And that epidemic is getting worse under the pandemic. We're seeing increases. There's a 4-fold increase in the number of Americans reporting rates of depression, doubling of the number of Americans actively considering suicide this summer versus a year ago. So It's just, it was a bad world in terms of the design of mental health services that we inherited, that we went into COVID with, and it's a worse world in some ways now. But there's some things that are better, and there's also a lot of things improving, like Melissa and John talked about, and like you all are actively working on every day. But still, some of these fundamental misdesigns in our system have to be dealt with. We have to get, I like to call it the physical and the other physical. Mental health we think of is a physical. We're pretty sure that there's a brain in here. I've never actually seen my brain, but I'm pretty sure it's physical. So, and of course, it's within a spiritual and a faith-based and community and an interpersonal context. But that's kind of the core of what we're trying to do. So let's start with the 86 legislature. Let's talk, before I talk about what happened there, we went into the 86 legislature in our initial planning for it, which began the day after the end of the 85th legislature in 2017. With modest expectations. So much had been done in the 85th legislature after the Mental Health Select Committee that Speaker Pro Tem Moody was a co-chair of, or vice chair of, I should say, along with Chair Poor Price. So much got done in 2017 that we were going into 2019 thinking we should probably do less. And we were planning to do that, but a big event happened, and that was Hurricane Harvey. And then another big event happened, which was the murder of children, young youth, at the Santa Fe High School later that year. So, there became a need, recognizing a need in Texas that we're going to do something about children's mental health. And so the legislature did. It did a lot about children's mental health. So I just mentioned that to say that, our plans don't necessarily evolve. Circumstances don't let our plans evolve in the way we thought they would. So a lot got done. Texas broached $8.2 billion per biennium. My son says, what does AF stand for? Because he thought it might stand for something else. It means all funds. And so $8.2 billion in all funds, state and federal, that the legislature appropriated for mental health, which was the first time we went over the $8 billion mark. And that included over $600 million in new funds. So, a lot of that went to local communities to expand mental health services. A lot of that went to build 2 new state hospitals, which, even though not directly benefiting El Paso, does take pressure off the broader system. $100 million went to schools and the school safety allotment that they were free to use on mental health. And that's over and above the $616 million actually going to mental health systems. And then almost $100 million went to the Texas Child Mental Health Care Consortium. $59 million to address population growth and equity, as in sort of geographic equity. So, a lot happened in the session that was good. And then also some expansion of just community inpatient beds. But I want to center on one thing that I think structurally was huge, and that was the establishment of the Texas Child Mental Health Care Consortium. The 12 medical schools that make up that consortium, one of which is Texas Tech Health Sciences Center here in El Paso, stepped up. It was not something that was just a natural choice. I mean, the program here has a strong clinical mission along with its research mission, but that varies across the medical schools. And also, it's not like they weren't already doing stuff. So to say, yeah, we're willing to do more, to build more capacity, to expand our residency programs, to make more of our child psychiatrists and adult psychiatrists available for Texas children and for the public mental health system more broadly, was a risky move. They didn't have to do that, and they did. And really hats off to those medical schools, and hats off to the medical school here in El Paso, because Texas Tech is a leader. They're not just kind of following. They're really out there among the top programs for engagement and enrollment of primary care providers, provision of consultation, engagement of schools, supplementing what many of you all are already doing in schools. I mean, it's not meant to replace. It's meant to be a supplement. But it was a really important program, and one that we intend to leverage going over time. It really is a key step here in being able to transform our children's mental health system to look like the rest of healthcare, or at least effective healthcare. And, this whole idea, by the way, of an ideal mental health system, that came from our system assessment in 2014. And I mean, it was Enrique is very good at getting me to do things I didn't plan to do. And I mean, and feel free to read into that as much as you want. He made me get my first cowboy boots. He took me to the Lucchese outlet store. So Enrique is good at that. Y'all are good at getting us to do things, because you bring a perspective that's hard won and incorporates viewpoints that other parts of the state don't. And that's true of other parts of the state as well. But this idea of an ideal system, I'd never thought about that until, it was part of the project in 2014. I'm like, well, how do all these pieces fit together? And I think part of that was, it's taken us a while as an industry to figure this out. So, the reason I'm so excited about the Mental Health Consortium is it is a key catalyst in leveraging up that system and sort of like creating a foundation, because the consortium supports primary care and the linkage between primary care and specialty care, trying to keep as many people in primary care as possible, because the reality is too many people don't get their care until they get to specialty care. And so that means we have to intervene earlier, and also helping us in schools with that sort of tip of the spear, with that sort of positive behavioral interventions and supports framework, or a multi-tiered system of supports. I think is the way I think about it. The direct services in schools. This is a great way to help coordinate those. So it's a critical, not just service, but a transformative component of the system to try to move us in the direction of early intervention and prevention, which is the only way to treat any disease. I mean, if you wait until people are in stage 4, you're going to have a harder time helping them. And it doesn't mean we won't always have people in crisis. Of course we will. But we need to get to people before the 8 to 10 years that it takes right now. So that's, what happened last session, a lot more than what I just said. Happy to reflect on some of it. But when we look ahead to the 87 legislature, it's a very different world. I expected in December to have a big discussion about mass violence that unfortunately your community was right in the middle of with, what I would consider a domestic terrorist attack last year, just over a year ago, and the trauma of that, but more importantly, the resilience of this community and how you responded and how you didn't blame mental illness in a knee-jerk way. How you said, mental illness is part of this picture, but there's a whole lot of other things that make humans violent, including ideology, including racism, and we need to look at it holistically. We were having a fantastic dialogue in the Texas legislature in December that you all contributed to, both through your suffering, but also through your insights. And we expected to make some real gains when it came to early intervention on psychosis, expansion of juvenile justice system services. All that changed when COVID happened, and not just because of COVID, but because of the effect of COVID on the economy. So we're going to talk about some of those changes, or the royal we is going to talk about that. So, the big word for this legislative session is uncertainty. So, a lot of things are going to happen on November 3rd. Fortunately, in Texas, we're probably going to know who our leaders are the evening of November 3rd or very early on November 4th. It might take longer for some of the federal positions. And, if you have questions about that, I'll try to answer it. But it's we're just happy if we can help Texas get better. We're not trying to deal with that mess in DC. I mean, we are a little bit, but this is our primary role. So, big question is, will the Democrats control the House? I think a broader question is the makeup of both the House and Senate, which is really up in the air. I mean, I think I've heard really good predictions saying it's probably going to be a little bluer, but also I've heard really good projections saying don't count on that there's so much going on. I mean, just, the Supreme Court dialogue this week is injecting emotions, positive emotions, people caring, and sometimes those overspill into not so positive emotions. But overall, people are animated, and I just think we don't know. So if someone tells you they know, just smile and hug them and let them have that fantasy, because it's probably helping them get through the next few weeks. The other thing is, how will government function in January 2021? The Capitol is currently closed to the public. We had the whole Sunset Commission meet without one public hearing. My friends in other states, who, like New York, where Linda's at, who had legislative sessions this year, all of the hearings were conducted by phone, because you can't do Zoom. It's not equal. People don't have equal access to that. The only equal access is phone. And even that's not fully equal. But so you sit there on the phone waiting your turn, and you talk, and you don't know who you're talking to. So there's going to be fewer committee hearings. There's going to be fewer opportunities to pass legislation. We know that going in. There's two things that will be certain. One is there's going to be a new Speaker of the Texas House. We don't know what party, but we know that there's going to be a new Speaker. That means new leadership in the House. And we know that there's going to be a budget deficit. The only question is how big. It's going to be at least $4.6 billion. There are estimates that put it multiple times that out there. And we won't know till January. A big thing is the federal government going to do anything about that? because the CARES Act has already sent over $11 billion to Texas that we're largely still sitting on. And you can talk about whether that's wise or not. But those funds, do we have the flexibility to use those funds? Will there be additional funds? That could go a long way to shoring up the rest of this fiscal year, which goes through August, as well as positioning us in a more healthy position without draining more of our rainy day fund for the next biennium. So that's a big given. Hopefully, I was encouraged to see Wolf Blitzer chastising both Nancy Pelosi and Donald Trump yesterday. I think that's good when the media is hammering on both sides to say, let's move forward. So we're very much into bipartisan chastisement. We would like the leaders to move forward and get some things done for the rest of us. But there's going to be 4 focal areas that are going to dictate what happens. And notice mental health isn't in any of these, but all of these affect mental health. Budget, just talked about that. COVID, big mental health impacts. And I'll tell you, I've been encouraged. I've been on panels with Senator Kolkhorst, who chairs the Senate Health and Human Services. I was on the panel that Arinke talked about last week with Chair Price and Chair Moody. And all 3 of them said we're going to have to do more on mental health. So that's good. You want people going into session saying we need to do more. The protections for mental health funding are still there. There was a little bit of a scare and some guidance that came out that didn't, from Speaker Bonin, that didn't explicitly say it, but Senator Nelson made sure the next day that everybody walked that back and was very clear that behavioral health funding, mental health and substance use disorder funding, and IDD funding continues to be protected. IDD was in there. Police reform, a lot of focus on unnecessary use of force and the impact on individuals, on racial groups, the systemic factors that lead to that, not just in policing, but in society. And a big part of that's mental health. The work we're doing on law enforcement suicide prevention intersects very much with the look at toxic stress on officers and how that spills out into all sorts of problematic things, including unnecessary use of force and excessive use of force. And then redistricting, which is going to make things very fun, because whenever you fight over a big carcass laying out on the Serengeti, the animals are not well behaved. So, and I'm sorry, by the way, for vegans in the audience. I should have had a better metaphor than that. But it's going to be messy. So those are the big things, right? And so you might see a range of poor behaviors happen. For example, it's possible that the only thing that really gets done next session is a budget. That you have a Democrat-controlled House and a Republican-controlled Senate. Maybe they don't want to do a lot of work together. Maybe they want to take advantage of the Republican governor that we have on the Republican side, slow things down, just pass a budget. No legislation gets through. That's possible. And so I think we just need to be prepared for, a range of possibilities. So at the Institute, we have sort of a best case scenario, an adequate scenario, and then a worst case scenario. And in the worst case scenario, we really are hoping that we all stand together. If we start saying, hey, let's cut the inpatient budget and hold up the community budget, or let's cut the community budget, or let's cut the special grant programs, then that's a recipe for disaster. The way that Austin State Hospital and San Antonio State Hospital got through last session with building both was they stood together and said, you need to build both. And so we built half of each of those hospitals, and they're now very well positioned to finish those hospitals, because it would be pretty stupid to just waste the 100 and 200 whatever million that's already been invested there. So standing together, and if we all have to take a little bit of a cut, taking it across the board as opposed to trying to throw someone else under the bus, is what we strongly recommend and what we're going to be pushing. And we need you all to think about, because you start draw knives on each other and start, hey, let's cut the substance use disorder funding. Let's cut the mental health funding. Oh, well, they're worse off than we are. That's not going to be productive. We need to stand together, and we're working on that. So a couple ideas to think about where I think we can stand together. One is telehealth. That's one of we talked about that earlier. It's not a panacea. It doesn't work for everybody. Not everybody likes it. But I'll tell you right now, access to healthcare in Texas is better than it's ever been. And that's because of audio-only telehealth, which allows people, even in where there's no broadband, people who can't afford broadband. I mean, that's the big thing. It's like, yeah, let's get broadband everywhere. Well, yeah, that's good. But we have broadband in lots of places and people can't afford it. So it's not just a matter of getting broadband out there. We have to use technologies like audio only. And we're very optimistic about keeping that in place. And we can use the budget to do that. That's not dependent just on legislation. It would be better with legislation. But even through budget riders, that can be done. And there's wide consensus there. And if you have concerns about that, I would recommend you try to get those concerns addressed rather than fight the rest of us who are trying to maintain these access gains, because it's not going to help anybody if we don't stand together on that. And there's tremendous consensus. And if you don't believe that access is better, then come talk to us, because we got tons of data about that. And if you believe that telehealth doesn't work for everybody, you are right. Good for you. Good insight. But it works for a heck of a lot of people. And we need to not let the perfect be the enemy of the good. And in fact, with many people, it actually works better because people aren't as anxious. It's easier to access care. So we have to do that. We also have to make sure that Texas continues to be leveraged to take advantage of the federal response to COVID. I've never had a federal lobbyist working with us before. We have this year, because it's been important to support our Senate delegation, our House delegation, as they've advocated. And you saw that between the HEROES Act, which had $1.5 billion for mental health, and the HEALS Act in the Senate, which doubled that to $3 billion to mental health, and now the most recent House bill, which doubles that and raises it more to over $7 billion for mental health and substance use disorder treatment. That's good. That's a really good thing. So that work is going on by us as well as others, and we need to continue it. And we need to keep cool programs. And the one we're going to be fighting hardest for is the Mental Health Care Consortium. We're going to fight for the hospitals. We're going to fight for community funding, everything else. So, we're going to be supporting the efforts to look at more Medicaid in this state, because we need to be taking advantage of everything that can help us. But the consortium is critical. And in fact, to stay where it is, it actually needs a little bit more money, because some of the funds got disproportionately spent in the second year. So that's going to be a real important piece. And we want to leverage and build that. And remember, if these things survive this session, they can be built on in subsequent sessions. So we don't want to lose structural things like the Senate Bill 292 jail diversion program, which gives counties and hospital districts a role and an incentive to be able to be part of changes. So, I could go on. There's many other things we're going to try to do. I'm happy to take questions on anything that you have questions and concerns about. But I wanted to share with you, those are, I think, our priorities. We all need, and I think the biggest thing I just want to say, and I'm going to reiterate this when we get into the questions, is we have to stick together on this. It's taken a long time for us to speak with increasing alignment as an industry between both mental health and substance use disorder treatment providers. And in this community, the trust you've built, the alignment you've built, not that sometimes we still don't trust each other, sometimes have different perspectives, but that's been happening across the state, and we need to really build on and continue with that. So with that, I'm going to ask my friend, Mr. Mata, to rejoin me here and help me parse through. Do we have questions? Are there going to be questions?
Can you hear me, Andy? I'm supposed to be a voice from.
All right. Oh, are you a disembodied voice? You don't want to? Okay.
Yes,
I am. But I'm good.
Or you can say, am I hearing myself? Well, anyway, we won't do that. So thank you for that wonderful presentation. It's a lot of information to digest, but certainly this is an area where I do want to take 1 second to really thank our state delegation for all the work that they've done these past legislative sessions. They really stepped up, and I think you got to work with a lot of them as these bills were being passed, and such a great opportunity for our community, where we've seen many of these grants come to pass, and more services that we've been able to engage here. One of the questions that I have that's coming up is when we look at things like addiction services, we're seeing, that there is that move to that it's not a moral failing. It is something that needs to be addressed in the illness treatment kind of arena. And medication-assisted therapy, we do have such shortfalls in connecting the dots on that with the regular healthcare mainstream. What do you see is coming to help us in that arena? Are we looking at primary care ability to provide medication-assisted therapy, those kind of things? Is that real?
Absolutely. Yeah, it is real. And look, we have a lot of specialty providers on the call, and there are absolutely folks with addictions who need to have a broad array of services and supports. There's also, everything's better if you have multimodal treatment, but there are decades of data from France, from other nations that have had liberal access to buprenorphine. That, my read of those is we should be dropping buprenorphine from airplanes. Because, look at the programs where they start folks on buprenorphine in emergency rooms and give them a 2-week supply. And, the criticisms I hear are like, well, they'll just keep using because they'll use that to deal with their withdrawal symptoms. I'm like, okay, like you want them to have withdrawal symptoms? I mean, like, do you really believe that's going to motivate them to somehow, improve their health if they're like physically ill? I mean, we really, I think, have to think through, would we do that with any other disorder? I mean, this whole sort of moral frame that frankly, we as providers are just as guilty of. Who's the biggest folks stopping liberalization of access to MAT? The Dr. McCants Katz, the director of SAMHSA, the American Psychiatric Association, which is the only medical association that is against that. And the reason they're against it is they have a handful of addictionologists and addiction specialists who are on the positive side enamored with how good they are and think everybody deserves access to their awesome care, which in a perfect world, yeah, but that's not the world we live in, folks. And then on the flip side, folks who are just frankly protecting their guilds and their practices. And I think, so the liberalization, I mean, just think about it. Primary care docs can basically prescribe as much oxytocin as they want. I mean, they'll be tracked on it, but they can prescribe it to however many people they want. But they have to have special training and a limited number of who they can help get over the addictive consequences of the medication they can freely prescribe. So we talked to Dr. Burgess, who's a Texas House member, who's senior member on the Energy and Commerce Committee that's looking at the MAT bill. And, he cares about this. Texas is fortunate to have him there. He wants to see what's going to come from SAMHSA's review, which I promise you will be negative on this because Dr. McCants Katz is going to write it. And she's a great person. I admire her. I like her, but I just disagree with her strongly in this area. And we just did a model, Enrique, where we said, what if we had universal access to MAT through primary care, particularly buprenorphine, but also naltrexone and some of the other meds? We could cut deaths from opioid overdose by more than half just
That's
using
amazing.
that. So folks, so if you all have concerns about this, I really would ask you to look at the big picture and not at your narrow practice and the handful of people, relatively speaking, that you serve and say, do you really think that you won't need to restrict the practice of primary care docs in order to protect the integrity of the treatment you provide? And the biggest people we have fighting us, Enrique, are providers, not the population in general.
So thank you for that. That certainly does. It is thought provoking, and it is one thing that I personally want to see more of that integrated care. I have another question here and this comes from one of our FLC members, our Family Leadership Council members. Actually, our vice chair, Kathy Gaitan. What do you recommend for us to do as a community? We have different groups participating on the FLC, and we want to do more to advocate cohesively. How do we consolidate those advocacy efforts outside of our legislators? What else should we be doing?
Well, I think, hi, Kathy. It's always enjoy talking with Kathy. I think getting aligned and staying aligned together. I mean, you all being able to, air your differences, note those, maybe help each other support. I mean, the more you can, one things I figured out this year when I was trying to broker some communications is the first 3 letters of my first name are and. And that's probably why I tend to like these win-win solutions, I guess, because the people have been calling me and E my whole life. So if you are disagreeing with somebody, try to figure out how you can get both of your needs met, because there's probably a way to do that. We're about to have a big consensus paper come out that we help broker between the American Psychiatric Association and the American Psychological Association. And that practice of how do we both win? And where can we both focus? That's one. The second thing is you got to focus. If you want 12 things this legislative session, great, good for you. But figure out the one thing you want most. And maybe the 3 things you're going to actually put some effort on, because you're not going to get 12 things this session. It's not going to work. It's not going to happen. So I think really, Kathy, what you guys can do there, and then share what you did. Share the consensus you've come to with your legislators, because they need to know that. Also, share that with me, and share that with our team, and share that with other people involved in this space, your associations. Tell us if we're advocating for something that's problematic, because we want to try to address that. I mean, we get tons of input, but so I think that communication and then trying to sort of prioritize are the most important things you can do. And then as you advocate outside, I mean, you're not going to be able to take a delegation to the Capitol. I mean, numbers aren't going to work. probably this session. What's going to work are people you know. So, find out who actually can talk to one of the members of your delegation, or maybe it's a member of someone else's delegation, or maybe it's someone on my board who knows somebody, and I think where it's going to be the people. And fortunately, you have leaders, and I mean, you have a lot of great leaders. The one I know the best, just because I've met with him so many times, is Chair Moody. And Joe Moody is somebody who knows this community. He's somebody who is approachable, who cares, and and so are the members of your legislative delegation. So in your community, it's a big community, but it's small enough that you have real relationships. Your kids go to school together. You suffered the same things over a year ago, many of you. So that kind of, I think, and I don't know if that specifically answers your question, but those are the things I would recommend. Consensus building, prioritization, and then personal relationships, because that's what's going to get, if they have 2 bills or 3 bills is all they can get through this session. Whoever can get to them and talk to them and help them with those decisions is how they're going to make those decisions. It's not going to happen, by taking a bus to the Capitol, because you're not going to be able to do that.
Thank you, Andy. I have 2 more brief questions. One of them was really quick about the 4th focal area. Can you please repeat the 4th focal area? I'm trying to understand what that was. I think that might have been in your.
Yeah, I put the slide back up. Redistricting. So I kind of glossed over it. It's a big thing. But once every 10 years, there's a census, which apparently is now going to be done. The Supreme Court just decided to let the Trump administration finish it up here in October. And so one of the things that they're going to do is figure out, how do we draw our House and Senate districts? And there's a lot of power that's distributed in those decisions. So that and the budget are the 2 things that are imperatives. Those have to be done. COVID and police reform are the 2 big issues that are going to fit in there somehow. And by police reform, there's broader racial justice issues, I think, that go along with that. But the focus is going to be on police reform. So redistricting was the 3rd one, or was the 4th one, I think. That was the 4th one I mentioned.
So I have one last question here, and it is from Rachel Quintana. She's with one of our FQHCs, Project Vida, and it's on interventions for homeless youth with mental health issues. They've been extremely challenging now with COVID, and outreach is much more difficult for us to connect with them. What are your thoughts on how we can do a better job of reaching out to these young people? Are you seeing anything that we might be able to do? They're fearful of reaching to us. That's what she said.
Yeah, Rachel, I mean, that's a very difficult challenge, and I don't pretend to have any easy answers, but there's a couple things that we've seen that are important. One is to recognize that mental health workers, substance use disorder treatment workers, are frontline workers, and we need personal protective equipment. We need PPE. And our patients need to feel safe. The people we talk with need to be safe. So, to think not just about PPE for you, but maybe PPE for the homeless individuals. And I know there's still shortages, but I mean, here's the thing. I mean, there's masks, and there's some pretty good masks out there that almost anyone can get. And so to put resources into that, and to really, keep that front and center, that it's not just for the healthcare worker, it's also for the individual you're engaging, to make them feel safe. And that's been a big thing across the board, not just for homeless individuals, but there's been an overall decrease in healthcare seeking because people are afraid. And they have good reason to be afraid. And of course, we know that homeless youth in particular have much higher histories of trauma, a whole much broader set of reasons to be afraid. Their fear based in their experience. So I think, to me, when you do that, and I think this is true for trauma treatment in general, anything you do to help someone feel safe is going to help. So making PPE a big thing. And you probably already are, but just, but embrace that and go with that. The second thing is, keep in mind that it's part of a relationship development, which I know but to me, one of the biggest things I ever learned with outreach to homeless individuals was a story of a person who had to basically put a sandwich out 42 days in a row before the individual would come into the clinic. And about the 15th day they set the sandwich out, the individual was willing to talk to them. By the 3rd week, they were having continued discussions and had built a relationship. So once that relationship's built, you can switch over into telehealth. You give the person a short-term phone, which, by the way, is probably a good thing for them to have. They may already have one, but like a phone that they can use. What a great way to stay in touch with you. And so leverage the telehealth. A lot of times we say, well, we can't use telehealth for homeless individuals. Well, yeah, we can. We just can't use it in the same way we would use it to somebody who has a home. But like my phone isn't in my home, it's in my pocket. And you can do that with somebody who's homeless. And they may lose it, it may get stolen. I mean, there's risks. It's not the same dynamics, but the audio only component of that can be really powerful. And then I think the third thing is that there are more housing resources in a lot of communities. And I wish I had looked at our report and the update on kind of where you're at in El Paso on this, but I know in other communities, those COVID dollars have been used to fund hotels and other places. So arguably, in some parts of our state, there are actually fewer homeless individuals sleeping outside at night because there's now COVID dollars going to hotels that would otherwise have been empty, housing individuals who are homeless, which I think is fascinating, isn't it? Like all it took was us to be really scared of a disease that we would all get for us to summon the will to house everybody. And some of that was fear motivated, and some of that was benevolence, and some of that was just clever local officials being able to use a windfall of federal dollars creatively. But I think those are some good things. And I apologize for not reading that ahead of time. And maybe Enrique, you can tell me about whether your local city officials and county officials are prioritizing some of the coronavirus relief funds for housing or not. Because if they aren't, you should ask them why. And if they are, applaud them, and let's try and keep those gains after the funds expire, which probably won't expire for a while. But Enrique, do you have more specific thoughts on that you want me to react to?
No, but I do think that the community is looking at those CARES Act dollars for some degree of assistance to homeless efforts. I don't have all that detail available right now, but I think we are certainly looking at that, and those are great ideas, Andy. And I did have a quick comment from someone who was asking how they can connect with you to discuss MAT legislation further. Are you available for those kind of discussions in the future?
Yeah, absolutely. I mean, we're sort of a no wrong door institute. If you email me, you probably should also email ISRA Merchant, because ISRA makes sure that I actually see all my emails. Our point person on that, working on that, is Nelson Jaron, who's our Vice President of Government Affairs, and Nelson's been real involved. The issue is it's really at the federal level. This MAT legislation, which we can, Enrique, if you want, we can get you a link to that and you can share it with folks. But it's at the federal level, and they basically need to get rid of these waiver requirements. I mean, right now, a primary care physician is only allowed to treat a couple hundred folks on MAT at a time, which that sounds like a lot, but it's not. I mean, like they're treating thousands of people in their practice, and those artificial limitations are just, I mean, that's really dumb. So yeah, reach out to any one of us, and but it's a federal issue that we need to deal with mostly. There are some state issues around like reimbursement for it. I think that the second thing is HHSC is trying, but I think could be more successful in branching out beyond their traditional providers with their opioid dollars. Certainly the hospital district here, in other communities should be getting some of those funds. I'm not sure that they are, but like emergency room and other things, we're really pushing the practice envelope here so that you're building partnerships with primary care, emergency room, other kind of non-specialist providers would also really help, because the more leaders see us doing this and doing the kinds of things that, like I said, I mean, if the people in France can figure this out, they're no smarter than we are. Texas can figure this out. El Paso can figure this out. So by figuring it out, we can really help, I think.
Andy, thank you so much for all of this presentation, for your leadership at Meadows Mental Health Policy Institute, and your willingness to be with us today, and also to help us with our comprehensive system assessment as we go forward. Your team is doing a great job, and we so appreciate all the work, the insight, and vision from your organization and from you. I so appreciate it. Thanks a lot.
It's our honor, Enrique. It's great to see you as always. What a great day you did today.
Great to see you too.
Everybody.
Thanks a lot. And I'm going to turn this over to Tracy for us to have closure, but I hope you all enjoyed the show, and we will post this information, as much of the information that was presented today, on our website link that you'll see out there. And we will be providing that for folks to review later on. And Tracy, I'd like to turn it over to you.
Okay, great. Thank you so much, Enrique, and to your entire team for pulling this together. It's been great to spend the morning with these wonderful speakers, thought leaders, leaders in policy and mental health in our state and across the country, and we are so grateful to them. And to everyone in the audience, thank you for engaging, for being a part of this, for staying with us. We're super thankful. I really think that we accomplished what we set out to accomplish, which was, one, recognize and celebrate the accomplishments of consortium partners, to hear from national leaders and statewide leaders on information, data, trends, and opportunities, and then also to be motivated, inspired to continue the hard work. Because we know as far as we've come, we have a ways to go, and we will leave here very motivated to do that. I know I will. I wanted to close with just a couple of additional housekeeping items, shout outs, things to keep in mind. I saw in the chat that people had recognized some of the city COVID related funds for rapid rehousing that the Opportunity Center for the Homeless is managing. The Delta Center, which has been a great part of the county, anyone that has been behind on rent since April, that is still open and available. And of course, we want to draw down all those dollars for families in need. So please share that. Also, we've had some ping-ponging with the census deadlines. Originally, obviously, it was April 1st when it was supposed to be, and COVID, of course, extended that deadline through the end of October. Then it went back to September, and now we are back to the end of October. So please, we encourage, if you have not completed the census, you can do that on the website, my2020census.gov, or by calling the census phone number, 844-330-2020. And also to share with your networks, help your participants, your colleagues, your family, your friends get counted. And El Paso has done so great with the Complete Count Committee, but we have a ways to go and we want to finish strong. So remember, through Halloween to do that. Also, we have a lot of nonprofit organizations on the line today and serving our community that are participating in El Paso Giving Day. Early giving runs through today, and at midnight tonight, we have up to $300,000 in matching funds that have been generously provided by Walmart that'll be available if you log in. givingday.org, all day today, midnight tonight, and then through midnight tomorrow. So our nonprofits need help more than ever. They have stepped up. They have additional expenses, as we've heard today, related to COVID, and many of them have not been able to host fundraisers like they might have in the fall or in the summer or in the spring, and so they really need our support today. And that closes our session for this year. So thank you again for logging on, for being with us, for all the work that you do for our community and for working with us and each other. We are so proud to be a part of the Paso Behavioral Health Consortium and to fund this work and so much of the work of the organizations in our community. So with that, I will close for the morning, and I look forward to seeing everyone in person as soon as we can. So thank you, and Godspeed to all.